what we have learned. We want to dedicate the sessions of this day unto your hands. May the Holy Spirit be amidst us as we deliberate, and may you continue to give us wisdom to serve this nation better. In Jesus' name I've been able to pray.
Amen. Thank you so much, sister. Colleagues, I want to humbly introduce our chair this morning. Dr. John Baptist Wanyai is the Commissioner Health Services, Emergency Medical Services at the Ministry of Health. And I want to ask you to welcome him with me with a big hand clap. Thank you so much, Doctor, for making time to chair this session this morning. And I want to ask you to take over from here. Thank you so much.
Good. Thank you, Dr. Agre, for that initial introduction. Good morning to all of you colleagues. As Agre has already indicated, this morning we are going to have two keynote addresses, and I'm here standing in for the Director of Health Services, Curative, Dr. Oraro Charles, who was not this morning. He arrived this morning late from Kabale, so he's still on the way. He'll be joining us later, but because of that delay, he asked me to step in. The program, we are starting a bit late. The program we shall start with the first keynote speaker, who will be Dr. Olive Sentumbe. Then the second one will be Dr. Richard Idro. So we have made that interchange. I'll start by recognizing Dr. Olive Sentumbe. I would like her to come and take a seat over, and Dr. Richard Idro. I want to be certain that they are in the house.
She's online, but her video is off. Let me give her a call.
Dr. Olive Sentumbe.
Thank you and good morning, Dr. Wanyai.
Yes,
I'm
you're
speaking
welcome.
in from the land of milk and honey.
Okay. Okay.
I'm seated
Thank
in
you.
Soroti.
Thank you. Thank you. Dr. Olive Sentumbe is going to be our first speaker, and Dr. Olive Sentumbe Mugisa is one of our very seniors. She's an obstetrician gynecologist trained under Makerere University. She has over 30 years experience and has been working with the World Health Organization for a long time as a family health and population advisor. She's one of our technical members on the technical working groups, various technical working groups, especially dealing with maternal and child health at the Ministry of Health. And she's also involved in male involvement advocacy, and she has participated in development of various policies and strategies for sexual and reproductive health. She's particularly interested in young people, in which she has been playing a role in their training. She has been on various UN joint programs and also supported the development of safe motherhood in various African countries like Liberia, Lesotho, and Swaziland. And she's also a part-time lecturer at Uganda Christian University and a board member for Social Justice and Development, White-Bone Alliance, and many of those. And I know most of us who are in this house and those online, you have all had either been taught or you have heard Dr. Olive Sentumbe speak. And allow me to take this opportunity to invite Dr. Olive Sentumbe Mugisa to give us the first keynote address this morning. Thank you. Please join me. Welcome her with a hand clap.
Thank you. Thank you.
Good.
Thank you very much, colleagues. Thank you very much, Dr. Wanyai, our chair today, Senior Minister of Health officials, representatives from the various districts, invited guests in your various capacities. Good morning. I am happy that you've given me this opportunity to speak about maternal health within the context of COVID. Right now, different countries are challenged because of what has happened, but we also are happy that services must continue, and therefore we all continue in that spirit to ensure that we sustain services for our mothers, for our children, and for our adolescents. Next. Next. Yeah, my topic is quality of care, really, in safe motherhood within the context of COVID-19. We'll be discussing a little bit, giving a small background. We'll show a few data sets we have on COVID-19 effects. We'll talk about the standards for quality improvement in maternal health. As you know, globally now, we are being financed, we are being supported, and many of our countries are being supported by the Global Financing Facility for RMNCH. A report has just come out showing a mixed progress really across our countries, and a more negative effect in the poorer countries, as of course expected, but of course showing that country leadership and long-term funding has been an effort to really sustain the services. There's evidence which shows that partnerships, really the different partnerships we have, and if you look also at Uganda, we have sustained our health facilities working, we have sustained our services, we have supported health workers, because we do have these various partnerships in RMNCH. We know that there are still gaps, but we are hoping that there will be more financing of data systems to ensure that the data sets we have are updated so that we are helped to make decisions on the current programming based on that. Next, let us look at some of the few graphs that have been produced, basically under the support of Bill and Melinda Gates, supporting WHO and various African countries to look at what they have. In 2019 and 2020, there has been a template format sent to us as countries, and we've been answering questions about how our services are performing in relation to sexual and reproductive health, family planning, GBV, and this is how the countries have performed in those 2 years of COVID. So I think you can see that there have been various disruptions, and there are various reasons for these disruptions, as you can see, ranging from closure of outpatient services and other RMNCH-related services going really low, looking at travel restrictions in countries, looking at financial difficulties facing our clients, looking at the fears within the communities. You know, they fear that they may contract COVID-19 if they come to our health services for RMNCH. So there has been a number of reasons as to why countries have performed like they have performed. And as a result, there have been recommendations coming out for us to ensure that we look at the whole health system holistically, so that we review what we have been doing, which has sustained some of the services that we are still able to offer. And we have to look at major inputs within the governance area. What have we been doing? How have we been performing? All those committees which we have had, which have been really been possible because of the good leadership and governance of governments. Make sure that along with COVID-19 technical working groups, there are also technical working groups for these other related services, especially as they relate to the infectious diseases and RMNCAH in particular. There have been various guidances and standard operating procedures coming up, even within this period of COVID-19, and the guidance, therefore, is not lacking. If we specifically look at family planning, for instance, in Uganda, there has been a general increase in family planning services. Unexpectedly, though, although in the recent past we are reporting a slight decline in the use of oral contraceptive pills. So that's how our pattern is now. While if you look at Ethiopia, for instance, which is our next door neighbor, and it was performing very well in post-abortion care, comprehensive abortion care, it has also gone down, again, because, you know, various reasons. Women can't reach the services, and that's what is happening in Ethiopia. Let's look at more data coming in for Uganda based on what we have submitted. Yeah, look at maternal and newborn health. There have been fluctuations in the of services. We go down, we come up. There has been various declines in antenatal, as I've said, in the African countries, and Uganda has submitted its data, and this is how it looks like. Fluctuations going low, coming up, low, low, coming up. But we hope that as we stabilize, which as it is currently coming out. Next. Of course, it has been said that if we want to ensure that we increase coverage for our health services, we must ensure that even within this difficult time, really, we are sustaining quality of care. The success of our universally reaching out will depend on us offering evidence-based care, which is effective and which is people-centered. I take away that even within this Director General, Dr. Tedros, let us maintain quality of care while giving services. We should ensure that we are giving timely services, they are equitably distributed, more so they are integrated, and that's what the reason why I'm in Soroti. We are looking at integrated service delivery. Are they efficient? Are they effective to the client who is receiving them? How safe are they? Are we really taking into consideration the issues and needs of those people? Are we there for people-centered? Those are the elements that will support us to give quality care. As RMNCH, we know that globally, we have been given targets to reach by the year 2030, which is only 8 years away. Given the current morbidities we have, as countries, we are going to have to establish systems which enable us count every maternal death. And I'm very happy that we are trying to do that as a team. In partnerships, we are trying to count the mothers who are dying weekly. But remember, our target is 70 per 100,000 in the next 7 years. We must end the preventable deaths of newborns, and that one we must reach the figure of 12 per 1,000. We must ensure universal access to family planning services and eventually universal coverage for all these RMNC services. This is what guides us as countries, and also Uganda has adopted the same targets to make sure that we are reaching where we need to be 2030. Next. Of course, when we give ourselves such targets, it's always important to remember where we have been. This is how we have performed in the recent many years, almost 30 years. But yes, we are coming down slowly. We are making hopefully steady progress apart from newborn care, but which is also seemingly lifting in the recent months, but we're affecting almost all the districts which we have. And as we've moved, it's being reiterated that we need to have a special program to address the current levels of adolescent pregnancy as a country, Uganda. It is really an epidemic of adolescent pregnancies, and it is bad indicator for us. So if you take away some of the things from this particular conference, you really need to work on adolescent pregnancy in each of your districts. Next, you need to make sure that your services for those young people, you need to give them information so that we together can address the reasons as to why we have the various maternal deaths that are occurring in our country. We are all aware now of hemorrhage, but hemorrhage is also bad within young people, and it's very common. So when you look at these RMNCH causes of maternal deaths, we want you to always relate to what is the exact picture in your district. Some of your districts now are coming up with high levels of eclampsia, higher than postpartum hemorrhage. But overall, postpartum hemorrhage, obstructed labor and ruptured uterus, infection, postpartum infection remain the key causes of maternal deaths in our country. And we must continue to address this as a problem. And I'm also glad to say that Uganda is taking on serious steps every week to address the pattern that comes out weekly as a cause of maternal deaths. Yes, next. We are looking for blood. We are looking for why are women not coming in time? And we are looking for reasons as to why our newborn deaths are really dying of prematurity, but also very big numbers dying as a result of asphyxia and our health workers being a bit unable to resuscitate these babies. So these are the biggest problems we have in MNH, and we relate it to the quality of services that we are giving to our people. Quality of care in RMNCH, but quality of care
Dr. Olive, we are losing you.
Overall, there is evidence in country, but also providers adhere to the above. But overall, not suffer actually. Hello, Swan and C, are you hearing me?
Yes, you are now clear, but we missed some seconds there when you started the provision of care is poor.
Okay, at least let us appreciate that even in high-income countries, 1 in 10 patients is harmed while receiving care because of poor quality of facilities. I don't know whether we have determined the quality of care. We are also looking at a number of poor sanitation facilities. So all these things, as they come together, they give us the poor quality of care we are offering, and we need to be thinking quality improvement in these areas which we have shown above. Next, go to the next. Okay, there is also evidence that women are experiencing abuse, lack of respectful care, compassionate care, and definitely for many decisions that take place around their childbirth processes, they are excluded from a number of decisions during this very important process. So we really need to make sure that we offer respectful care, we listen to them, and we reduce the long waiting times for them as they come to the health facilities. Next. Let us now look at the standards quickly, because that's what will improve our services. And why are we talking about the need to refocus now and pay a lot of emphasis on the different elements of the standards? It is because we are having increasing number of births happening at our health facilities. We are also seeing that we have the same vision. Every pregnant woman and newborn receiving quality care. And we now know that the period around childbirth has been identified as the most cause of maternal and newborn deaths. We want to reaffirm that priority across Africa and other countries. Next slide. We are being as to why mothers and newborns die. As this next slide comes on, we must specifically look at our skills and birth, especially as it relates to monitoring labor. Your current guide on monitoring labor and the new guides that will come. We must all look very closely at the newborn when it is born. How is for it if it has a problem? We have this. We all have the skills to manage, to prevent also postpartum hemorrhage. Do we know how to manage difficult labor? When we need to do cesarean section, post-cesarean section management, do we have the various technologies and medicines that we need? Are we skilled to ensure that pre-managed and they get out of our health facilities alive? Are we able to give the mothers and the newborns of infections after birth? These are the major causes of death, even in Uganda. Going forward, we will have to make sure that we have the skills and the environment that is required to address these different packages, because we have also been able to describe what it will take. Next. The inputs that we shall require to ensure that we reduce maternal deaths, that we reduce newborn deaths, we reduce stillbirths, is going to make us address the 3 major investments which are going to give us a triple return, really, if we can address them effectively. But in order to address them effectively and causes inputs, and we all need to look carefully at those inputs, otherwise it is difficult to offer quality care. We need Next. It is indeed going to be important for us to appreciate that it's a wide coverage, it's a wide scope of services we are talking about. We are talking about covering labor, childbirth, postnatal periods, focusing on the priority areas, being women, newborn and family-centered. This time around, we have to ensure that we are receiving also the community engagement, that mothers and their families are involved in the services we are giving. And we are talking about all health facilities. If we ensure that right from health center to the district hospital, we are caring, we are ensuring that these key thematic areas that have been mentioned, we are all skilled and equipped to handle them, we will really reduce our health facility-based mortalities, but also when communities begin to trust us, we shall also reduce those that occur in the community. Basically, the standards we are talking about now, which have been adopted by Uganda also, have the provision component and have the experience of care, which is the new area. All along, all of us have looked at ensuring that we provide evidence-based practices, that we provide actionable information systems, our DHIS2, HMIS data sets, that we actually have a good referral functioning system for referrals. That one is what we have been knowing how to do, although not very well, but at least we've been working around there. What we have not been doing very well is effective communication to the people. And this is quite important as a standard. Sometimes we have not been respectful. Sometimes we don't understand how to preserve the dignity of those people who access services in our health facilities. And we need to do that better. We need to be offering them emotional support as they enter with all their fears in our health facilities. How are we able to comfort them and provide the comfort they need? But who is going to do this? Our standard 7 talks about having a competent, motivated human resource team, and partnerships and the government are going to help us do this. And of course, we need a good infrastructure for the health workers to be able to perform. So the standards, which we are now describing in a little bit of detail, although not so much because of time, continue please. We are just going to show the structure, how these standards are designed. We've got 8 standards, which we've already mentioned, 31 quality statements, and 350 quality measures. But we are free to select the priorities we are going to be taking forward as a country. Next. I think we can skip what is a standard because everybody by now has learned, but the quality statements which follow this statement, standard statement, help us measure the inputs, the physical inputs, the human resource inputs, and the guidelines which you need in order to be able to implement that standard. And that's where we are getting it wrong. We need inputs. With just a mention of a protocol, you will not be able to implement it if you don't have the necessary inputs. And I think going forward in 2022, we must examine what are we putting in. If we are just putting in standards without the necessary inputs, then we must focus on the inputs. we must also focus on the outputs. If we implement what we have said, does it lead to a desired care? Does it lead to a reduced morbidity, mortality component? What is the effect of you implementing that standard or that protocol or that guideline which you have so well described? That has been a weak area for us, and government together with other partners, we need to lay a lot of emphasis on the inputs required to implement a standard. Next. Next. Let's look a little bit more. These 3 standards, which I said we are all used to, are that every woman receives routine evidence-based care and management of complications during labor, childbirth, and early postpartum period, of course, according to the WHO guidelines, but we've now adopted them to the Ugandan guidelines. But they are not far away, they are the same. The health information system enables us to use data and ensure that we are taking appropriate action according to what the data is saying. If the data is saying you are constantly not having adequate numbers of deliveries in this health facility, yet you are seeing very many more in ANC, please do something about it. Look for these matters. The 3rd standard relates to referral. If you cannot manage a mother in your health facility, please ensure that there's a system to refer her to where she can be managed. But along with those clinical requirements, we are expected to offer effective communication. We are expected to be respectful and dignify the clients. And we are expected to provide to every woman and her family emotional support that is sensitive to their needs and which strengthens their capabilities. If we shout at women, for instance, who are not progressing well, they will even retard further. The progress will even be slower. If they have hypertension at 160, 110, they are coming in late, and we shout, it will even go to 180, 120. So these are the practical things of that part of this 4, 5, 6 standards, which are supposed to target the client. Let's look at 7 and 8. For every woman and newborn, we need competent, motivated staff that are consistently available 24 hours, no absenteeism, to provide routine care and manage complications. But for this to happen, the health facility must have an appropriate physical environment, adequate water, sanitation, energy, medicine, supplies, equipment, so that we can manage these complications routinely. Of course, studying that number 1 standard, for instance, it goes in detail to talk about the woman when she's admitted during labor and childbirth, she's provided with that timely care. The standard 1 also says newborns must receive routine care immediately after birth, because missing any of those can actually take you into a negative picture for the baby. And within that standard 1 of offering evidence-based practice, we expected to offer mothers and newborns routine postnatal care. Why? The highest number of maternal and newborn deaths actually occurs in the immediate postpartum period and those 7 days that follow. We've mentioned those critical areas so that we can now move to the next. This is just for re-emphasis. So how are we using these standards now that we know what is contained in those standards? As a country, as partners, we are expected to use these standards to prepare the evidence-based national standards, which we have done in Uganda, and we must congratulate ourselves. But we need to introduce and benchmark them in all the health facilities and see how we are performing. And we need to ensure that we are tracking and monitoring improvements. We have all set up to ensure that we develop our QI projects or programs based on what our gaps are. And they're different because we are different health facilities. But really, we need to audit ourselves. We need to regularly assess ourselves so that we can address our performance routinely rather than a one-off. And therefore, the journals about all those different quality improvement projects, I hope you are setting up in your health facility. This is really like reassuring ourselves that we are on track. It is not going to be possible for us to keep improving if we don't keep asking questions around what we are doing. But as I said, the country and the partners must ensure availability of the country. We have been able to establish the policies, the strategy structures, but we are currently building on making sure that we have coalitions, stakeholders, and partnerships. And that is also going on very well, really, for RMNCH. But we need to partner more. More partners, even outside the usual. The Rotarians, the private sector, all those people will have to come in to pick up from where we are. We need a detailed analysis of what is happening by district, and we need to ensure that we identify who we can learn from. Right now, we've gone beyond the 6 initial districts, and we are continuing to learn from several districts, but we must document who is doing what and who is doing it well, what has he or she managed to do well, and how can we learn from them so that we can go to scale. We need to agree that we will have to collect indicators so that we can monitor our current performance. We are not short of that, even for those 15 core indicators, as we shall see them. The country is trying to work on them before even the next revision of the DHIS2, so that our DHIS can adopt all the 15 core indicators. But strategically, it is important for us to learn and continue to take forward the leadership processes at the different levels. We are expected to strengthen our leadership skills at the national level, district, health facility, and the community. We must accelerate what we are doing now, and we need to learn from those who are doing well. So please let us provide the learnings where you have them, your innovations to help us deal with the current issues that we are dealing with. Above all, we must become accountable by the use of the data and accepting the data that we have so that we agree to work better. But very important, we must now ignite demand for quality of care. And therefore, our close working with the community is going to be a very big step next and going forward. Yes? Next slide. We have challenges as a country, but they are not insurmountable. We are all working on the insufficient awareness on danger signs, low status of women, poor education, now the girls are getting pregnant, poor health-seeking behavior, low male involvement, low quality of services. That's what we are working on. But it is important for us to recognize these challenges we have. And you as a district, as a health facility, you define what you're going to do about them. It's not enough to know them, but we want to know what we are going to do about them. These are the 15 core indicators that have been agreed upon globally as what all countries will be measured against, so that we are comparable. Uganda has picked 7 out of them, but there are new areas of work, for instance, like basic hygiene provision of those sanitation and water things, which we have not been doing very well. we need to pick them up. We just need even to introduce simple things like weighing scales to be able to get these measurements of the newborns so that we can fulfill some of these indicators. The reason why we may not even be able to do indicator 12, documenting birth weight, some health facilities, by the way, don't have these birth weight scales for the newborn. So the inputs are really required. We may not do very big things, but we need to have to build a will to address even those indicators which look simple, but they are not being determined because we do not have what is required to pick them. We must all embrace integration and make sure that all our existing plans pick and add what we don't have from what we have described. It is going to be important for us to continue to demonstrate success and build on what we are all doing. What is possible in AMDAT we have been may not be completely possible in Jinja, for instance, which is a very upscale town. But what is possible in Jinja may also not be applicable in Katakwi. So those are the small details we all have to deal with. And therefore, calling for long-term and predictable financing is one of our most important advocacy areas. Without adequate long-term investments, it's difficult to achieve the quality we described. And we must take a whole health systems approach. We must address those building blocks of WHO for the health system if we are going to address the main obstetric causes of deaths and newborn deaths. Next. Because different women and different babies come with different complications which you need to deal with. So it is a health systems approach. We must be careful to be planning and dealing with the poorest and the most marginalized communities who cannot easily access a health facility even if they want. We must definitely implement mainly the proven interventions and empower women, families, and communities to seek for timely health care. But we have also learned lessons within this COVID time. You see, we've learned that we have had to coordinate very strongly between various technical working groups to ensure that nobody is left behind, and that the RMNCH receives a balance of measures in our effort to mitigate COVID-19. It's a huge area of work, and we have learned that, and we've done something about it. The government has had that holistic approach. At least Uganda can report guidelines of COVID within RMNCH. The importance of helping and supporting the health workforce with what they need has become very apparent during these COVID-19 challenges. The PPE, the IPC, whatever you want to talk about really affects a lot of the RMNCH service delivery. So we need to ensure that we have substantial innovation where it is possible, but where it is not possible, how do we improve on what we have? Different districts have had district-specific subnational decisions to make, but in an effort to provide service for the women and the newborn and ensuring that the healthcare worker is also being cared for. We have had to provide timely data almost every day. much more important for RMNCH. The role of the private sector now has become obvious in Uganda, which has provided us with a lot of support, a lot of transport support, communication, coordination, and we need to strengthen that. And therefore, resource allocation, budgeting, and accountability mechanisms will have to be built in what we are doing, much more than we have been able to do it before. And understanding that decision-making is dependent on all this put together. Next. It has been obvious, as we've said, that we are developing new challenges, but we are also trying to do something about them. And I think it's important to continue to say, okay, even within the new waves, new virus variants, and the COVID-19 vaccination campaigns, what is it that we can do as RMNCH and all the other partners, and how do we advocate better? We have shown that data has been powerful, and I think from our standpoint as WHO, we want to congratulate Uganda. It has been very positive in providing its data. All the time it has been called on, we have been able to inform the rest truthfully. By the way, I think I'd better add that word, that this is what we have now, but we are working on it. So I think let us continue with that sharing so that we can learn from the others, but they can also learn from us. Integration and coordination must be an area we work on very well in the coming days. We must focus on the hierarchy between patients and providers within the healthcare system. Continuing to reflect on our issues within a life course approach under the guidance of the national level coordination and collaboration. As I say and continue to say it, the good relationship that has existed between the RMNCH programs and the emergency response is something that we need to build further, but also recognize our achievement. Because when we do not recognize what we have been able to do well, you may drop it, or discontinue it, and yet that is what supported the system to continue. Next. So addressing this early emergency response and planning for it and making sure that everybody is involved is the way to go. Activating existing resources where they are in the community, in the private sector is something that we shall continue to talk about so that we can plan and support activities directly and indirectly when we are responding to COVID-19. I think we are being given as an example, Ethiopia and Uganda. We have managed to provide what we have and what we have done, even the innovations we've shared. Next. Improving infection prevention and control in MNCH services and facilities, looking at those digital health technologies which we are all coming up with, and of course, not forgetting self-care and family care practices. These are programs that are becoming stronger and stronger in Uganda, and we need to embrace them. There's an urgent need for data quality. We have provided the data, but we have to keep checking our quality of data. And we must learn to triangulate data from the different sources and continue to strengthen advocacy for data sharing between countries And I think next steps are obvious to all of us, linking MNH implementation sites with management and decision, and establishing learning systems, strengthening routine measurement, developing and implementing accountability mechanisms that integrate community and explore, especially this time now that these children are getting pregnant, but not in our hands. We really must build the accountability mechanisms for the community. And we must explore mechanisms for engaging the private sector in delivering quality maternal newborn services. I think that is what I had to say. And therefore, going forward, let us ensure that we are strengthening the referral linkages among primary health care facilities. We are building our QI teams, and we are highlighting the need to strengthen our clinical mentoring systems that are ongoing now and supported by the World Bank and other partners. I speak specifically for Uganda, which I know what is going on, that we are struggling to make sure that our clinical mentoring systems are on. And given what we are seeing now in the districts, they even need to become stronger so that our care service providers have the critical skills they need to offer services. Thank you for listening to me and giving me this opportunity to talk about RMNCH quality improvement and COVID-19. Thank you.
Thank you so much, Dr. Oliver. A big hand clap for her. Thank you so much, Dr. Olive, for walking us through that very enriching keynote address. We shall, due to the time limitation, we shall keep our questions until we have the next keynote speaker, then we handle the questions later. Usually, of course, keynote address is not supposed to have these questions, but the organizers have been gracious and they have allowed that when you have the questions, we need to forward them to the presenters. But we are very, very grateful for that enriched presentation, especially relating what has happened over the period of COVID, the disruptions which have occurred in maternal child health, and referencing the SDG goal number 3, and the positive trends of indicators in Uganda, and the fact that we need to target certain thematic areas as priorities, and also thinking more about the poor, the disadvantaged people whom we need to make sure that the service can be able to reach them. And for the districts, the delegates here from districts, there is something Dr. Olive was emphasizing on the issue of your district analysis. She's giving the global picture, the national picture, but she again said we need to think locally at district level. What could be the cause of this maternal death? What could be the cause of the newborn death, and so on? But by and large, the issue of ensuring that the 3 areas of input, output, and outcomes are focused on becomes key. But keep your questions and inquiries to after Dr. Idro's presentation. Thank you, Dr. Olive, and let's give her another hand clap as, thank you. I was informed that Dr. Idro will also be presenting virtually. Okay. Good. I've been informed that Dr. Idro is going to share by himself. So please, Dr. Idro, you are free. As Dr. Idro comes on, I just want to give you a small summary about him. He's Dr. Idro is a senior lecturer at Makerere University and also a visiting fellow in the tropical medicine, a visiting fellow in tropical medicine at University of Oxford, and a honorary consultant at Mulago National Referral Hospital. Commonly, all of you know him as the immediate past president of Uganda Medical Association. He led us through this period of the COVID-19 pandemic. Dr. Idro trained from Makerere University in both the basic medical MBCHB degree and M.Med degree. He had also his PhD training in clinical neuroscience at the University of Amsterdam, and his specialized training pediatric neurology at the Institute of National Transformation. Dr. Idro sits on various boards, and he's one here at the national level for the Strategic Committee for COVID-19. He is also on the boards of Epilepsy, Global Health, International Child Neurology. But if all of you can remember, in 2015, Dr. Idro was an African Research Leadership Awardee when he led the study and control of nodding disease syndrome in Uganda, and also in 2019 got an inaugural Greenwood Africa Award. He's also part of the WHO committee that developed the 2015 severe malaria treatment guidelines. I want you to welcome Dr. Idro, our senior lecturer, our great researcher, and our past president. You are welcome, Dr. Idro.
Thank you very much, Commissioner. I hope I am audible and clear in the hall. Good morning, everyone, and the leadership of the Ministry of Health, and especially the Quality Assurance Division. It's a pleasure to have been invited to share with you some of our thoughts, especially in the last 2 years as Uganda Medical Association, and the experiences and the lessons we learned through. Now, you may be aware that Uganda Medical Association is the umbrella body of all doctors in Uganda and Ugandan doctors in the diaspora. So we represent about 7,300 doctors in this fraternity. And the vision of the association is that all the people in Uganda have access to quality health and quality healthcare. And as a mission, we aim to provide programs and advocacy to support the social welfare and the professional interests of doctors in Ugandan doctors. And through it, promote universal access to quality health and quality health care. We operate through 15 branches around the country, and these branches are around the regional referral hospitals, except the Rwenzori region, where Rwenzori branch is with Fort Portal, and recently we resolved to create a South Rwenzori branch to cover the areas of Kasese and its environment. So in other than the national leadership, we also have branch executives all around the regional referral hospitals. And so many of our doctors operate through the regional branches. UMA being an organization, an advocacy organization, our main task is really advocacy towards, again, as I say, the welfare of doctors, the professional of doctors, and also the quality of care to the population. So we usually look at identify problems, define a specific area, see whether there is a policy stream where we can develop some solutions, and even if this one involves whether this has a political angle, whether it doesn't, and if a policy window opens, that is where we try and get in so that we can influence these particular areas. And how do we do this? This is relevant to what we were doing during the COVID period. So in conducting the activities, this is our inside game. In conducting the activities of UMA, we look to identify our needs. What are the interests of our members? And of course, the main thing is welfare and professionalism, but also advocacy for community. And then we see how we can focus on the most important. We identify opportunities which are available, map areas of power, and in a bit so that we can be available around the table. Because as somebody says, if you are not near the table or at the table, you will be on the table yourself. So, and then we use the strength of our numbers to try and address this. We use the skills which are available in the membership. So it's really voluntary work. So we call on our different members. We appreciate them, and people usually readily volunteer to give in their skills to address specific areas. Carefully using the media, but specifically we try and nurture our young so that they grow. So in almost all our leaderships, we have a mixture of the elderly, the middle age, and the young. And through these different interventions, we use synergy with other professional bodies to try and build this. And really, this kind of actions or a plan of action is what we used in our interventions during the COVID-19 epidemic. You may all be aware that Uganda's response, the national response to COVID-19 was centered around 8 key pillars. Key among which were leadership and stewardship, and coordination and oversight. So we are the major pillar in the leadership of the country to oversee stewardship, coordination, and oversight of all the different areas. Community engagement and social protection, so involving the community. The president did quite a lot of this in himself. For us in the clinical work, in the healthcare part, there was a lot of work with case management. So a lot of UMS work was in case management. We have surveillance and the lab services, continuity of essential health service, which is the topic of this discussion, risk communication and social mobilization, so involving the community, but actively and continuously communicating what risk is there, and for us, including to our members. Then there's strategic information, research, and information among other areas. Now, as UMA, we did not specifically follow these areas, and a lot of our actions actually evolved with the progress of the epidemic or pandemic. And we focused on selected areas, which made sense to us. And as we learned more of the epidemic, you may all be aware that this was a new disease. We hardly knew anything about it. And using the little available knowledge and what was available, we kept refining and moving our interventions and discussions in both the leadership, but in the involvement of doctors. So again, we went back to what we do, advocacy, but also in providing leadership to our membership, but also leadership to the community, especially where that time became necessary, and I will elaborate on that. A strong area for us was case management. What do we do with patients? Then with time, we realized the need to engage the population significantly, and how to continue with essential services, which is the topic of this discussion. And then, of course, the protection, care, and welfare of our members, and especially when it started hitting us hard. So for us, our areas really focus in about five of these major, our pillars were slightly different from what government was focusing on. But it was not as well defined as it appears now. It kept on emerging and engaging as the time went on. Now, following the initial announcement of the epidemic, not in 2020, but 2019, of announcing the appearance of a new epidemic, our first engagement with the public came in February, and then it was a press conference. And in it, we had specifically two objectives. One was to pass some information to the public. That time we thought actually the Ministry of Health was taking time to pass this. Although the ministry was engaging, it was actually engaging the public sector and preparing itself for prevention. And we did not see an adequate preparation, especially in the private health sector. Our feeling was that the private health sector will be the area to be hit first, because the people who travel with planes will mostly go to these private health facilities. So our engagement was in that. The next thing, within a few weeks, especially when the first cases were then described in, I think, in Egypt and in West Africa, we sat down and started asking ourselves, what will we do when the first patients hit our clinics? Because by that time, there was no guideline, and we did not have any particular thing emerging from the ministry about this. We remember contacting a few of our membership, some in WHO, some in the ministry, others in private practice, others in policy, others doing different areas, including anesthesiology, critical care, public health, and we asked them to think through what should we do when the first patient comes. And as we started making these initial engagements, including with the emergency services, we're happy that the Ministry of Health got on, and immediately we ceded leadership of this to the Ministry of Health. And this then came out as the first guidelines for the management of COVID-19. And rapidly came the need for addressing misinformation. There's feedback. Oh, okay, it has gone down. So the need for addressing misinformation coming out from different areas, including from the political spheres, and then the first lockdown, which brought absolute chaos. And this is the first area when it started impacting on the continuity of essential services. Many of you recall with the lockdown, suddenly there was no preparation of how health workers could move. And within a few days, I remember being invited by the security services to think through some of these elements. We do not have, for example, for doctors, we do not have a universal identity card which could allow people to just use at points of care. How could nurses move to hospitals? some nurses got beaten, some health workers got beaten on their movement, and it actually brought to fore some of the early actions which were, I will say, ill-advised. For example, land and buildings which are near hospitals, which had been given away because now many health workers were living very far from health facilities. And so the need to create identification and then reorganize transport systems. This was first followed by the challenges with PPE. That time, I recall the Ministry of Health initial focus was to deploy PPE in the treatment centers. But for us, our feeling was that all health workers, wherever you were, needed to be covered with PPE. There were challenges with accessing PPE around the world. It was very difficult to access it. And so it was bringing a lot of conflict in some of this. And with the lockdown, initially the feeling was that the lockdown would just last a few days or a few weeks, but then the extension started, and it was clear that many essential services were being grossly impacted. People needed to go and get permission from RDCs, which were very, very, very inconveniencing. It was not compatible with emergency services. So we remember around that time, we actually engaged the leadership of the country on some of this. And we're happy to have received during the subsequent engagements, but the head of state then allowed even health workers at Health Center 2, Health Center 3 to fill in some of these forms, starting with the RDC in Hoima, who set the leadership around that time. We also engaged government on HDU care, and especially around the time when the drive was for the vehicles for the district health services. We thought that it was really important right from that time that we should improve HDU care, 4-bed HDUs for children and 4-bed HDU for adults in each general hospital. That was our dream. This engagement progressed over time, and so it evolved with subsequent more media engagement, correcting a lot of misinformation, and we then went into occupational safety and health, and we engaged the ministry, we engaged the Ministry of Gender, Labor and Social Development, and working with UNACO, we were able to start putting together occupational safety and health guidelines, which although initially was not accepted readily, but eventually a lot of this got accepted because it was setting standards, basic minimum protective standards, and many of which we're adapting actually from the WHO programs and making it relevant to what we had in the country. We were happy on engaging the leadership of the country that one of our elders was added to the National Task Force, particularly to try to drive home the importance of occupational safety. We really thought that we should protect our health workers and occupational health and safety beyond infection prevention and control, because most of the activities of the ministry was focused around infection prevention and control, but not the wider spectrum, the wider field of occupational health and safety. I'll be sharing aspects of this with time, but developing, and then we went on as the situation, especially with the second round came, was the need about home-based care, advocacy for continuing essential services. And when it started hitting us very hard, we developed a Caring for Carers program, so for health workers who will get affected. And in the last days, we started vaccine advocacy, of course, continuous professional development. And part of this information, especially with home-based care, was with the different groups who were vulnerable. So let me pick a few of them and focus on them. For example, occupational safety and health. We did put together a team which will look at occupational safety beyond the infection prevention and control. Their mandate was to train health workers, develop tools, information which could be readily shared, which will address the fear of the health workers. Just like other other members of the public, even us as health workers, this was a new disease which could kill us, and indeed it killed several of us, and especially when the first cases of health workers infected occurred in Lira. And so it was important to be able to address fear, to address the mental health of people who were working, who could not access their families. They were being restricted, where even family members will fear you coming into contact with them, and then developing appropriate standards of care for us. We engaged in fundraising, and we are happy for different groups which gave us money, both for the media coverage, but also for moving around the country. We really moved around the country and engaging small groups of health workers. And in the second phase, we actually then started targeting high-end, highly affected areas, and where we training of selected health workers from different health units as trainers, so that they could pass this message of occupational health and safety. And then, of course, I have talked about the guidelines which we developed. As time went by, we started losing our colleagues. And one of the things which we thought we should deal with was to find time and try to mourn, because really it was tough. So finding a method how we could mourn together. We invited family representatives of some of our colleagues who had died in this time initially it was in 2020 up to the beginning of 2021, and we prayed together for the nurses, for the clinical officers, the lab personnel, the pharmacists, the dentists, the doctors. We had a joint interdenominational prayer with representatives of all these professional bodies. Really the families felt that although they buried their loved ones during difficult moments, there was caring for them. But things of the second wave really started biting very painfully. And especially you who may be in the ministry, we had just finished in politics, and then with time also cabinet was dissolved, the ministers were out of office, and there was chaos all over. So as UMA, we sat down and we decided that we're going to spend several weeks on home-based care, because we're having so many people coming to hospital, but coming extremely late. There's so much abuse of so many different drugs that we should pass information. So we decided to occupy the media space for actually several weeks. Almost every single day, we had people on almost all radios and all TVs trying to address this. We developed what we call the UMA frequently asked questions for home-based care. We had even had hitting messages which were releasing initially weekly, and then after that, it actually even more frequently, to provide clear guidance and to the public. But we also decided to provide some guidance to the health workers. We knew some of the things will be difficult for the ministry to communicate. For example, we just wrote to all the directors, all hospital superintendents, and all doctors to scale down almost all elective procedures. OBD clinics, that we start scheduling them even for chronic care up to 3 months. Give adequate medications up to those kind of durations, and including not having more than 20 people attending a single OPD care, using the phones more. Actually, some of those guidelines were really well received by the different health workers. And the bit here was to ensure that essential services could continue, but safely. I recall, for example, during the first wave, we even initiated and tried to engage government that during the food distribution, could our nurses who immunize go with the people people providing vaccination, so that in the different homes they could update the vaccination of children, because we're really concerned that if this thing lasted long, diseases like measles will come back. Although this was really essential and not taken up, but in some areas, some DHOs tried to deploy such methods. The second wave was the most difficult time for us. In the second week, from the third week of May to the end of the second or third week of June, we lost 4 doctors every single week. Personally, I buried, I don't know how many doctors. It was some of the most difficult periods for us. So this was the time when we tried to improve on the caring of carers program, because we had so many health workers who were suffering depression. So addressing the mental health, I really want to thank our teams in psychiatry and clinical psychology, who set up programs. They put up rotas, and if a colleague was identified, they'll sometimes even drive there or call and have people calling so that they could talk to healthcare workers, because these were the soldiers, and if their mental health was in disarray, there was no way they could offer even the basic services, the continuity of basic healthcare services. We looked at starting to work with especially the ambulance services, and I really want to again thank the emergency services, the ambulance services, and KCCA in trying to work safe transport systems, and so that we could transfer even our health workers. And then with the groups of hospitals, we started identifying hospitals which could help and provide care. And some of this happened after we had lost some of our colleagues, including during transfer. And at this note, I want to thank TMR Hospital, Molago Hospital, especially the deputy director who really we engaged with to offer this, the Women's Hospital, MedPal, Victoria Hospital, who provided these different arrangements to try, and Case Hospital and Nakasero Hospital in trying to develop these systems. Now, COVID-19 has taught us that if people can mute, somebody's mic is on. COVID-19 has taught us a lot of lessons, and actually it shows that we can do better, and actually we must do better. And I'm happy to say that I think there are some things we're starting to do, and one of which is the emergency medical services. Mr. Commissioner, who is chairing, we want to congratulate you for the work which you people are doing in emergency services. But when you look at it, for example, the large-scale vaccination program which is going on, it demonstrates to you that we can actually do a lot more in this country. If we think about it, for the past several years, we have been spending nearly 150 million shillings on treatments abroad. But I've put the picture of this women's hospital, the Women's and Neonatal Hospital, the specialized hospital. That hospital cost less than $30 million. That money which we spend in 1 year can build 5 of those hospitals. What it tells you is that in a space of 3 years, we can construct all our regional referral hospitals and equip them to look like this with the money which we take outside of this country. I just wanted that one to sink in. that we actually have resources which we spend outside. And if we applied these resources in this country, we can actually transform the health services. There is a lot of wastage internally, yes. For example, just this year, during the annual health sector performance review, we were informed that the money for wages which was returned to the center was almost 79 million. That one could employ most of the people whom we need to employ. But the impact of the restrictions and the movement limitations also affected some services, but some areas improved. For example, the respiratory tract infections and diarrheal illnesses with hand washing markedly reduced. But when you think about it, hospital admissions for malaria during the other period, the period declined by almost 22%, or suggesting that some of these people might have been treated at home, and some of them might have died. But this is now an opportunity for us to rethink programs, and like what the malaria program was doing. How could we combine the two? Why survive COVID-19 and then die out of malaria? At the same time, can we critically think and address these concerns concurrently? And this is possible. And we have precedents. We can do many of these things. For example, I've just mentioned what the malaria program was doing, what the Women's Hospital, we have been able to do that. That money is available. And here I'm sharing two examples. One is in the private sector. Other than Kijabi in Kenya, which is a missionary hospital, I think there may be no other orthopedic center which may equal Kumi Independent Center. But we developed this one. Our colleagues, Dr. Ekure and colleagues, developed this one by themselves in rural Uganda, and it is working. It's one of the only centers outside Kampala and outside the big cities with an MRI scanner, and providing quality orthopedic services which you can get anywhere in the world. So it can be done. The other alternative is here, this lady who is wearing the face shield. COVID taught us to innovate, and many of our alcohol companies started making hand sanitizers. Plastic companies are able to make shields, showing that we can do it. And supporting private health sector was key, and especially when the cost of care started rising. As UMA, we supported them through as the government engaged them in curtailing the prices. And through this kind of support, here this was a meeting in President's office. Through this kind of support, they were able to find some middle grounds. What were the things driving the cost of care? And what could government do to try to bring this one down because of the public outcry? And they were being blamed for some Nakawoya Florence. Okay. Yes. The other thing was using the same kind of facilities. We have engaged the government to start thinking about medical credit facilities. How can we support our healthcare facilities? And we are happy that government is now considering this. And recently, the president wrote to Ministry of Finance to start discussions with private practitioners so that their businesses can health businesses can be improved. As UMA, we have had a very strong support from our elders. I had mentioned that we have a mix of elders, the middle age and the young doctors, and our elders have really supported us very strongly during this kind of engagement, thinking through what we have been doing, and we are very appreciative and with the kind of support which We have had multiple meetings, and they will call or you call them for advice at the slightest areas. So the other areas we have been engaging in policy proposals to government, and how the ongoing and the emerging challenges will be engaged. And we use the WHO models of the six building blocks of the health sector. And one areas, and these are some of the areas which we think that even going forward beyond COVID, some of the areas we, especially the ministry, we should be thinking about. How do we balance preventive and curative medicine in engaging and allocating more of our resources into preventive care, but not forgetting the curative services? Because right now, actually, the Ministry of Health is starting to do better and better in the preventive services. Infant mortality, child mortality, they're all declining. Dr. Sentumbo has just shown us that even the neonatal mortality has started coming down. Maternal mortality is coming down. Life expectancy is going up. But when you go to our curative services in the hospitals, really a lot needs to be desired. Just the other day, we went State House, and for you, especially in the leadership, these are things you should take critically. The president said that maybe we can increase the health budget to 3 trillion. Right now, it is 2.3 trillion. So this one needs to be fixed quickly, and part of it is to take into account some of the things which we put to him. The other area is regulation of training and practice. We have real problems with regulation of our training. And unless we start doing things right, in the future, we are going to have problems. The tools which we need to use, and how to finance it, and thinking about alternative costs. For example, can we start thinking the health center 3s? Already many of them have solar units, so that we spend less and less on electricity, that we transfer most of these recurrent costs for paying for power and removing them literally by using solar, or sinking boreholes and putting solar pumps so that we do not literally pay national waters. Things like that, thinking completely outside of what we have been doing. And of course, this is related to thinking about infrastructure. And a big one is the human resources, and which, since we are UMA, we deal with that. That is what we deal. I'll share more. I've already described some of this, but one of the best innovations which is coming out to improve especially services in the general hospitals is the idea to have the 5 specialists in the next financial year, ensure that we have these people. Having a pediatrician, an internal medicine specialist, a gyne, a surgeon, those people will improve the quality of care in those units. You'll have senior cover to supervise the medical officers. You'll have senior cover to supervise and support the clinical officers. There'll be improved level of care, especially for the very sick. And you will start seeing the reduction in the number of people who die. Of course, we are very glad, and again, just on this, as we met the president this week, he repeated, we introduced this suggestion to increase the number of MOs in Health Center 4 and introduce the position of MO in Health Center 3. Now, the practicalities of implementing this means that we need to have the appropriate DHO, not people in acting positions, having those senior positions. Half the posts of DHO still are not filled. That kind of thing is not any good. Of course, it means that the tools to use will be there, the infrastructures will be there, but they can be rotated through the general hospital, or they can be rotated through the Health Center 4, and a DHO who is well equipped will be able to manage. They don't have to stay at the Health Center 3. That kind of thinking can be implemented. I talked about the Frank Rubambida promotions plan, which we'll do. There are several other proposals which we put to government, including thinking about recentralizing some of the leadership, including medical superintendents and the general and the medical officer special grace in the general hospitals, and even creating the position of a deputy DHO to allow somebody to grow. And lastly, the insurance for health workers, reallocating the resources, reallocating the resources for which are currently, for example, URA has from the same pot as insurance. Several parastatals, judiciary. But if this money was all put in one pot and advertised for companies to provide insurance, public service or financial just need to top up, and almost all public servants will be able to be covered. And this is the premise of where we started. Currently, 40% of the posts, I'm using doctors because that's what I'm best versed with. Are filled. And if you think about senior posts, it's actually only 25% of those posts are filled. But we have people. And so we have a paradox of unemployment when the people are there. We are training over 500 doctors, we're training over 150 specialists, and yet we are returning money. Jinja Hospital just returned 1.2 billion. Fort Portal Hospital returned about 800 million. Almost all the regional referral hospitals returned between 400 and 1.3 billion, 400 million and 1.3 billion shillings. They could recruit, and we could fill this and have the human resource to deliver the kind of quality, we're talking about quality, the kind of quality services that require. I had mentioned about regulation, planning for services, professionalism, and training.
Excuse me, Dr. Idro.
Yes, please.
I'm getting a little bit limited in time. I would request that we move faster. My apologies for that. Good.
Oh, okay, 3 more minutes and I'll be done. So regulation of both the training and the services. We have to rethink all the medical courses in this country, and we have to check what the quality of our training are. This is something for the future which we should look. We should look at issues of governance, recruitment. There's a big problem, especially with the district service commissions. That really needs to be looked at. The other one is the clogging of the system. And again, to public service and to the ministry and the Health Service Commission, we have made proposals to try to see how can we improve this. You can see, for example, for doctors, if you're in public health, you are a medical officer, senior medical officer, principal, and that is the end. There is nowhere for you to go after that. For those in the clinical, there are only 4 steps. But if you're in the judiciary, the army or police, there are almost 12 different ladders, so you can continue growing. So how can we improve this? So we have made some proposals to try and improve this. For quality services, again, rethinking innovatively cost saving. Malaria vaccines have recently been approved. How can the program in malaria think about deploying these vaccines versus the cost of treatment? We are having a growing problem of NCDs. Our life expectancy is rising. In this country, we almost do not have geriatric clinics. We have child clinics, but now is the time for us to start thinking of clinics for the elderly and how we can reach them, because some of them have problems reaching to hospital. People are living much longer. Cost sharing was taken off. How can we think about cost sharing again, or the national health insurance? Our thought in Uganda Medical Association is that we need to start with this. National health insurance. and it grows slowly. But also innovatively thinking about technology and thinking about chronic care. There is no need for many of the patients for people to come monthly to come and collect refills. It wastes space, it occupies time. We can rethink all these clinics and think about up to 3 monthly visits. And also start thinking about looking at the medication at the different levels. Because when we get the specialists to go to the general hospitals, then we need to increase the spectrum of medicines which go there. Already we are seeing, like in our clinics in Molago, children with sickle cell who are on hydroxyurea, they rarely fall sick. But around the country, these medications are not there. If we did that, we will decongest these clinics. Very many of the children who are currently dying will not die. What kind of health services do we want? We are thinking that it will be an equitable service. It will be something which all of us can benefit across the country. Our rural folk are getting a raw deal compared to those in the urban centers, efficiently and effective. The 3 is, but the underlying question here should be equity. As UMA, to Ministry of Health, we are ready to work with you, involve us. Our methods may not be orthodox. They may not be like the straight ones for which the Ministry of Health uses. They are different, but they can work. And all of us, you are part of us as the Ministry of Health, and we all want a better health system and care. So involve us early, involve us in the planning. And many of us can just do it. Many of the health workers, they'll do it voluntarily as you do the planning. But also think about putting aside a budget for UMA because it can help you deliver. And this is just the recent interventions when the vaccines were expiring, and we just engaged all our branches, all the DHOs, and within the weekend, there was no need to force anybody for any DHO to resign. Within just 1 weekend, we had exhausted all the vaccines. So involve us, it can work. And this is another example. We went to West Nile, and within a week, we offered specialized care to over 15,000 people. And really, with an investment of about 300 million, we had over 100 specialists. We can deliver quality services in this country with just a bit of organization. I want to end with an advert. This is a book which is available. We have recently written this book. It is part of our history to celebrate the people who led medicine, who taught us, who set up these systems which we are now enjoying. We are writing a book on about 100 of them. This is a book of the first 27, including starting with Sir Albert Cook, but also the first 3 doctors who trained in Uganda. It's an excellent book. Buy yourself a copy. They're currently available at the UMA offices to access. At Uganda Medical Association, we say if you want to go fast, you go alone. But if you want to go far, you go together. And we are here to join you, to be able to go together with the Ministry of Health and to celebrate improvements in quality health and quality health care as in our mission. Thank you very much, and thank you for the invitation.
Good. Yes, thank you so much, Dr. Idro, for that enrichment. Members, let's give another warm hand clap for him. Dr. Idro, we are quite blessed to have you, and as a president who led through the difficult times of COVID-19 pandemic, almost I think 80% of your period you were handling issues of COVID-19. But with no fear of contradiction, the Ministry of Health appreciates the role which UMA had in the response to this pandemic. And as you have rightly noted, you did have focus areas, which were not exactly like our 8 pillars, but these were very helpfully identified and contributed to our good response. And by and large, all of you, especially those who belong to the UMA, you saw the role, especially during the first lockdown, which he has greatly outlined, and all these issues of which developed until we went into second wave. What I can say is that the response was made much, much better because of the strong collaboration between Ministry of Health and the UMA. You saw in the last slides some of the new things which UMA is focusing on. I think most of the health workers have been thinking so much about employment, and we want to appreciate you, Mr. President, for the advocacy for the positions, the changing positions for the doctors and other health workers, because in their submission, here he reflects the doctors, but a doctor doesn't work alone. So in that structure, you see that the Ministry of Health did the expansion to cover that. So we greatly appreciate that input. And one which I want all of us to appreciate them for is the issue of emergency response. Even now that the UMA declared a strike, still they have urged the doctors to continue with the emergency cover, and that is great. It means that we are doing advocacy, but also sensitive to the lives of the people. So please let us give them a warm hand clap for as UMA. Thank you, Dr. Idro. And I had allowed that we shall have some questions, but I'm doing very, very badly in time. So I'm going to ask you to submit the questions to the Secretariat so that those questions will be given to our 2 speakers this morning, Dr. Idro and Dr. Olive. Then the response will be forwarded to you on the chat before this conference closes. And I was informed that we received our director this morning, Dr. Okware Joseph. Allow me announce, I think he's seated somewhere. I received that information. Dr. Okware, you are most welcome to the conference. And given the limitations in time, I've been informed that from here, we shall just break off to our sessions, and more details will be given by the MCs. Thank you so much for your attentive listening this morning. I wish you the best in the next breakaway session. Thank you, and to you.
Thank you very much, Dr. JB, and thank you for steering us well through the keynote addresses. Good morning, everyone. We are going to proceed to the breakaway sessions, and I've been reliably informed that you can grab a cup of coffee or tea, but you will have to enjoy it as you go through the sessions, and also still be conscious of your security. Know your neighbor to ensure that we are all safe, and I wish you a good deliberations during this final day of meeting.
People should be mindful for the program, but exactly 4 shall also all be here for the closing ceremony. The ministers.
Yes, thank you very much. I've also been informed that in the various breakaway sessions, we need to ensure that we strictly adhere to the time. Presentation should be kept short and simple. The minister is expected at exactly 4 p.m. To preside over the closing ceremony. I wish to request you to grab a cup of tea quickly and proceed to your breakaway sessions. Thank you. Yes, the sessions are in Speak Ballroom, which is this one, Mahogany and Acacia. The theme in Speak Ballroom is medicines and health supplies and health management information. Mahogany will have service delivery and special groups. Acacia will have health financing, service and service delivery. The one here is moderated by the chairperson is Dr. Gerard Mutunji. I think is already here. Service delivery and special groups in Mahogany will be chaired by Dr. JB Wanyai, and health financing and service delivery will be chaired by Dr. Agre Matesaki. Thank you.
There is a bag here, and I don't know the owner, so can the owner pick the bag before I call the police? And for those who are staying here with us, please grab a cup of coffee and we start. As you've heard, we don't have time. I hope the presenters are ready. Please grab a cup of coffee and be ready to come back and we start. And I would prefer if you could come in front, those who are staying here with us, if you could come in front, and we have a good session. I hope it's safe. Is Mafabi Twaha here? through weekly stock status reporting in Dokolo district. So please give him audience, and you will have a few minutes of introducing yourselves. Tell us what you are, and then you go ahead and present. You have strictly 15 minutes for presentation as we wait for Mafabi Twaha. So joining me in welcoming Henry Jackson Ogwar, maybe with a clap, and he starts his presentation.
As the supply chain specialist for Rights North Lango project. I'm in front of you here to share the experience from Lango region, one of the district, Dokolo district, on how they managed to maintain stock visibility despite COVID-19.
Our IT is, the presentations are not showing.
IT, please.
IT, please. I see weak or no signal. What does that mean?
Thank you. So I said I'm in front of here to share our experience from Dokolo district in Lango region, how they managed to maintain stock visibility, which is very vital during the COVID-19 pandemic. We started with situation analysis of the district and challenges that was affecting stock visibility. Dokolo district has a population of 221,400 people, with about with one health center of 4. Yeah. And about 9 health center 3s. 5 facilities are ART sites, and those are the sites that we are reporting on ARVs, TB medicines, and HIV test kits. These supplies are usually monitored on a regular basis. Before COVID, there were several ways we were doing it, but when COVID came in, it became difficult to carry out some of the activities. So you can see the goal of supply chain function of the district is to maintain uninterrupted availability of commodities at all time. So this has been done through the regular cycle of planning, ordering, management, and then use, and then reporting. Before COVID, we had several ways of trying to improve on our visibility of the stock status that can help us to use the data in order to maintain, to inform actions such that we maintain stock visibility and availability. So when COVID came, there was restrictions in movement, there were SOPs to be followed, and there was heightened fear among health workers about the infection. They feared they could be infected anytime. So what strategy did we use? We realized that the real-time ARV stock status, which is an SMS-based reporting, was the option that was left for us. So we had to rely on it to ensure that the stock status of the vital commodities like ARVs, like TB medicines and HIV test kits are reported through the RAS system, the real-time ARV stock status reporting system. However, we had a challenge. There was low reporting and also inconsistent reporting in some of the sites. Because to use that data, the reporting should be as representative as possible for the district. So we had to strategize to see how this could be done. Which methods did we use? We started by analyzing the gaps and bottlenecks, like I said. In some slide to come, you may see a bit of the details of this. But the actions that we took were based on this analysis that we had done at the onset of COVID. We realized that there is a need for monthly RAS performance review meetings in order for the teams to review the progress, to look at the existing gaps, and also formulate actions to ensure that the reporting is going on well. This is usually a meeting led by the DHO and then involving the RAS users and the facility managers. We realized that there was capacity issues, knowledge gaps, so we addressed this through mentorship and technical support to the staff who should be reporting. We also realized that there were some users that were very consistently reporting, performing very well, while there were others that were lagging behind. Then we realized that recognizing the performance also motivates them to do better, also motivates their colleagues to also perform. So this motivation is like even before the DHO, he calls you and tells you that thank you for your work in front of your colleagues. It has been very motivating to them. Also, we allow them time to share their experience peer-to-peer. We realized that there were inactive users who were trained. They were trained, but they were inactive. Also, we realized there was general transfers in the district, and sometimes this transfer can take place, and then a person is transferred away from the ART site, sometimes to a site that is not even reporting for us. So we had to see a way of mentoring more staff to replace the ones that are either inactive or has been transferred. So we allowed peer-to-peer interaction both during the meeting and also at the sites by facilitating a good performer to move to a poor performing site in order to improve on their performance. We also had challenges of system stability This system was new, and sometimes it becomes unstable, and when the users send reports, they don't receive feedback. This was a bit discouraging, but what we did was prompt coordination with the system administrators from METS in order to fix so that the users are not discouraged. We also did data use, we improved on data use by the facilities and the district. When the data is collected, the data has been reported. It is used to make decisions. Who is stocked out, who is understocked, who is overstocked. This motivated even the facility managers to embrace this weekly RAS reporting. What did we see after this? After these efforts, we realized that all the sites that were reporting on RAS improved tremendously. In real figures, the reporting rates improved from 75% to 100% in Dokolo district in all the 5 sites. This was very representative, and every action you take basing on this data would be a little bit more informed. So with improved stock visibility, actions were based on data, and this improved on the availability of the commodities and also minimized waste. Because if a drug is about to expire, you identify that and redistribute and make sure that it doesn't expire. The graphs you're seeing is a representation of what took place on average. You can see how the reporting rates staggered at the beginning when we started this around August. But finally, by the time we were in July 2021, the reporting rate was already at 100%, and this has been very good for Dokolo district to maintain the stock. So, under our discussion, we realized that the rollout of RAS was really a savior to improve on the stock visibility in the face of COVID, and this was very positive for the health worker. The ministry guided that we select a storekeeper and HIA, who are the core people to provide these reports, and you realize the storekeeper is in touch with the stockers and the store all the time, and also the HIA is in charge of the data reporting. So this has worked very well as a strategy from the Minister of Health. So consistent and accurate reporting became very important, because if you're looking at a data to make a decision, that means the data should be representative for the entire district. So the consistency and accuracy became very important for us. So RAS data use for decision making strengthened the impact, because the buyout, after using the data and improving on availability of commodities, even the facility managers were impressed. They embraced and started giving support to the reporters. The slides are frozen. Okay. I was talking about the bottlenecks. You can see a few of them there. Knowledge gaps, what we did, training of the users, and then mentorship, constantly focusing on the poor performers. Lack of reporting tool. The RAS reporting was rolled out by the Minister of Health, but the tools were not easily available. So we decided to print booklets so that it can facilitate the reporting. Unstable system. We constantly engage the METS group, who helped us to ensure that the system is up and running, so that when people give reports, they get the feedback. And we also encourage the users, when the system becomes unstable, we encourage them to try make multiple attempts to enter the data, at one attempt or the other, it may be able to go through. There was poor reporting rates. This one we solved by having monthly review meetings led by the DHO. We recognize best performers so that they can be able also to encourage their colleagues to do the same, and then the peer-to-peer. We seem to be having a poor signal.
Our IT colleagues, what is happening? They managed to solve this in the district of Dokoro. We are failing here in Munyonyo. The challenges they solved in Dokoro, we are failing to solve them here.
No, I have a thing left with only one or two. Should be the last two. Just conclusion. Let's wait a bit. The technical team is working on it.
As we wait for our IT, I want to recognize that amidst us we have the Director for Governance and Regulation. Maybe you can stand up and wave to the team. We are privileged to be with you in this session. Director Governance and Regulation, Dr. Kware, can you wave to my people? Yes, he's with us here. We were enjoying a presentation from Dokoro, all the way from Dokoro district. Their technology was going on very well. The slides were very good. But I'm wondering what is happening with our IT team. And this will affect our time management. We are doing well with time.
So we shall just go to conclusion. What did we learn? Ownership, stewardship, and monitoring by the district and facility leaders have been very key to the achievements of this. We realize that where the ownership is very good in the facility, you get better reporting rates. In conclusion, Improve stock visibility through RAS reporting aided better stock monitoring in local districts, and therefore availability of the commodities, and also in the same vein, reducing waste through expiries. Our recommendations are that, one, RAS reporting should be strengthened and institutionalized. Secondly, we think that some of the rights to the system be delegated to the district. For example, when you train new people, you want to put them into the system to start reporting. I think this is a simple task that can be delegated to the district through the biostatistician, who is the custodian of data in the district. And then we need to also try and strengthen the ownership, like I've said, so that the response can be better. Thank you very much.
Another round of applause to Henry Jackson Ogwal. Thank you very much, especially for bringing out other ways of motivating workers. He said a call from the DHO motivates him very much. Sharing of experiences. I hope you have been motivated by sharing in this conference. And others, I hope you have noted your questions. We shall ask at the end. Due to the interest of time, we shall call another presenter. Can I request Mafabi Twaha to come and give us his presentation? And I hope others are getting ready because we don't have time. I have not seen Namoviru Bridget. Please, I hope you are in the house. Oh, okay. And Ediau John. Ediau John are in the house? Oh, okay. So the floor is yours. Introduce yourself.
Thank you. Good morning, friends and colleagues. I'm called Mafabi Twaha Nangoli. I'm a clinician from Tasombale. The wise men come from the east. We wrote an abstract in Medicines and Health Supplies, ensuring timely access of nevirapine syrup at birth by HIV-exposed infants at Tasombale. I was the lead author, but I was also assisted by other people, like Navuga Christine, our M&E, Wenwa Valentine, Dr. Sandekile, Mafabi Caesar, and Okech Moses. The presentation has not been introduction. We currently in Uganda, we have around 1.5 million people who are HIV positive, and of those, about 1.3 are on earth. And of those 1.5, they give us around 120 babies yearly. The Ministry of Health recommends that nevirapine prophylaxis at birth for such HIV-exposed infants to prevent them from acquiring the HIV. In March of 2021, due to the COVID-19 lockdowns, we realized only 5 of the 10 in our cohort had received the nevirapine at birth. Because of that, it was a big gap. So we instituted a CHI with an objective to improve the nevirapine prophylaxis coverage at birth to 100% by September 2021. The methods we used, they are the common things we did, but we had to just re-energize and re-emphasize them. We did cohorting cohorting of the pregnant mothers by the age of the pregnancy and the expected date of delivery, tracking and monitoring of these HIV mothers during their ANC in an improvised register. Such a register didn't exist, but we had to improvise it so that it serves us to do our work. We re-emphasized the routine health talks at ANCs to sensitize mothers and their partners on the benefits of EMTCT. Regular updates of mothers' contacts and physical location was also very important. Mbale is a cosmopolitan district. People keep migrating from one place to another, and without updating the physical location of the mothers and their partners, it can be hard for follow-up. So we took it upon ourselves to do updating of their contacts. Then we dispensed the nevirapine syrups at the last ANC. Health talks on how to administer the nevirapine, and also supporting mothers to pre-pack the syrup with the mama kit at the moment they are supposed to go to the hospital for delivery. TASO being classified as a health center too, we don't do deliveries. So we depend on public health facilities to conduct deliveries for our mother. So our emphasis was to make the mothers prepare the mama kit together with the syrup so that they move along with it. Then the follow-up phone calls to the mothers to re-emphasize the messages, and also to emphasize the mothers to pack the syrup as part of mama kit. Then reminder phone calls around the expected date of delivery to confirm delivery and the initiation of the syrup. Those were our results. As of March, like I indicated, only 5 out of 10. So that gave us a 50% performance. Then in April, there was some progress, 10 out of 13, which gave us a 77% performance. In June, we hit the 100% mark because we had mastered our art. In June, we made a drop, but it was because the mother was out of her home when we did the follow-up. In July, we went back to 100 till September, where we clocked 100% all through. This can be best visualized on the graph. It was a steady increase with a minor glitch in July, which we addressed in the preceding months. Discussions. Scientifically, we all know that nevirapine syrup prophylaxis works. Our package improved the coverage of nevirapine among the HAEs at birth. The data used for cohorting HIV-positive pregnant mothers also helped us achieve our set goal. There was improved awareness of nevirapine and its benefits. We made it a point to explain to the mothers and their partners on why nevirapine is important. Then improved the monitoring and tracking all the pregnant mothers during ANC. Our improvised register enabled us to make sure that we follow these mothers in real time. A mother who delivers and initiates the nevirapine syrup, we would tick off that mother. And those who would not have received, we would make sure that we follow them physically. Then the mother packing the nevirapine syrup with mama kit. We all know that mama kit is the first component of a mother going to deliver. So if the nevirapine is packed with mama kit, chances are high that the mother won't forget the nevirapine to move along with it. Then the follow-up phone calls all through the period of pregnancy. They enable us to do what? Follow these mothers and have a good relationship with them, especially during the COVID-19 lockdowns where they were restricted movement, and access to art clinic. It's not moving.
Oh, they are moving now.
Conclusions and lessons learned. Cohorting, monitoring and tracking, sensitization of benefits of EMTCT, timely dispensing of developing health education on how it is given, plus follow-up to confirm delivery and initiation is very important in yielding positive health outcomes for the HAZE. Lessons learned. This is what we learned. When we do the cohorting and monitoring and tracking, and also the phone call follow-ups, they enable us to book these mothers for first PCR, for a timely first PCR. If the mother has confirmed the delivery, it is easier, and you make a phone call, it is easier for you to book such a mother for the first PCR, which we all know that must be done between 4 and 8 weeks after birth. Then the follow-up phone calls. When you call a client to remind them about what they should do, first of all, it makes them happy. There is concern that my Musao thinks about me. So in us achieving our target, we are also creating a good patient-doctor relationship. And a good patient-doctor relationship is very important in service delivery. Hello, move again. Next slide. Recommendations. This intervention package is feasible and can be scaled up in health facilities providing ANC and not maternity service to improve coverage among NVP coverage among the HAZE at birth. We see that if we have tried it out, us would provide ANC but we don't conduct maternity services. I'm sure if this is picked up by other facilities who are like us, it can be very, very important for the service delivery. Last slide. Finally, this has been possible through the help of PEPFund, you said, through Uganda Protestant Medical Bureau, in association with the Ministry of Health. Thank you for listening to me.
Thank you, Mafari. Indeed, wise men come from the east, and you've kept within the time allocated. And you've really educated us how innovations can work, packing and developing in the Mama Kit, improvised the register, but also those reminder calls. Of course, my question would be, how sustainable is that in other facilities where they have few health workers, maybe there's no phone call, there's no airtime. Maybe we'll answer that during the discussion. But thank you very much for that wonderful presentation. I think we can give him another round of applause as we invite Edward Mugwanya. I'm told Edward Mugwanya's presentation is recorded, but somebody will answer any questions. I think he sent somebody to answer any questions. So if controlling malaria upsurge through hotspot mapping and targeted outreaches in Albertong district, Lango sub-region. You said rights, North Lango experience. Are we ready with that presentation? Okay.
Good morning, colleagues. I'm making a presentation on controlling malaria upsurges through hotspot mapping and targeted outreaches in the district of Albertong, Lango sub-region. In Uganda, malaria vector control mostly relies on use of long-lasting insecticidal treated nets, and indoor residue spraying. We also know that there are other measures like larviciding and environmental management. The district of Aleptong has had several rounds of these interventions. The last round of IRS was conducted between May and June last year, achieving a coverage of 95%, and mass mosquito net distribution was concluded in July the same year. Scientifically, we know that these interventions are expected to cut off the man-mosquito contact and thus reduce malaria transmission. Despite these interventions, malaria cases continued to rise. A post-IRS malaria upsurge was observed 3 months after the intervention, with a cumulative number of cases increasing by 119% if you looked at the situation before and after the intervention. We therefore set out to investigate the cause of post-IRS malaria upsurges in the district. This graph is an illustration of what I've just shared. Between May and June is when we had the intervention. It is evident that the cases before the interventions are much lower than the cases we observed after the intervention. What did we do? There are 21 facilities in the district. In each and every facility, a malaria normal channel graph was reviewed to identify 2 to 3 weeks, showing an increase in malaria cases above the epidemic threshold. Again, the epidemic threshold is known as the upper limit. On the extreme right is a picture of a malaria normal channel graph.
Recording stopped.
We then line listed 100 confirmed malaria cases from OPD registers for the same period of time using a standard tool we obtained from the Malaria Control Division. An Excel pivot table was used to count malaria cases per village. A village that recorded 5 or more counts, and the counts here, the cases, was identified as a hotspot. We proceeded to organize targeted outreaches. Communities were mobilized in the hotspots, and we tested individuals using RDTs. Individuals that had malaria parasites in their blood, in other words, who were positive, were given a full course of antimalarials. We excluded individuals who were currently on malaria treatment, or those that had completed malaria treatment within 2 weeks prior to the engagement. What did we find? 44%
Recording in progress.
of these individuals had malaria parasites in their blood with no signs or symptoms, and these are the asymptomatic carriers. We observed this in about 83% of the targeted malaria hotspots, and I must say here that we did not reach all the planned 106 hotspots because we had limited RDTs. We observed 20%, rather 26% reduction in malaria cases 2 months following this intervention. It is interesting to note that malaria test positivity among our communities with these individuals that had malaria parasites in their blood, but we are not showing any signs or symptoms. And here we are referring to them as asymptomatic carriers, varied widely with a range of 11% to 72%. It is therefore evident that there was a high proportion of individuals in the communities with the malaria parasites in their blood, but not showing any signs of sickness. That targeted treatment of asymptomatic carriers interrupted transmission, resulting into the overall reduction of malaria cases in the district. What is the take-home message? One, that patient-level data serves as a compass to identify areas with the pools of asymptomatic malaria parasite carriers, and targeting them contributes to a reduction in malaria transmission. Two, asymptomatic carriers act as infectious source pools that propagate malaria spread. We therefore recommend that in high burden, high malaria transmission areas like Lango region, screening and treatment of asymptomatic carriers should be prioritized among other malaria interventions. I thank the people I worked with. They include Rebecca Nikeka, Emmanuel Deke, Epiang Francis, Pamela Dong, and Angela Katen. Francis Epiang is a malaria focal person of Aleptong district. Thank you for listening.
Thank you very much. I think this study is very useful for our malaria programs. It has brought up the issue of asymptomatic carriers. And not many people have thought of this. We are only interested in those who come, we test them, we treat them. We don't know that they are asymptomatic carriers who are the source of the infection. And treating them, treating asymptomatic carriers reduces the prevalence of malaria. This is very interesting. Finding that up to 72% of the residents were asymptomatic carriers. So maybe other people may think of massive treatment of malaria irrespective of whether they test you or not, probably would reduce the source of infection greatly. So thank you very much for this very important study, and I think it's very beneficial to the malaria program to think about controlling malaria. If you have questions, somebody will be available to answer, so please take note. And now I want to invite Namubiru Bridget on improvement of oxygen availability and efficiency in its usage on the COVID-19 patients. I want to thank my presenters. They are really keeping time. So I hope you won't be the exception. The floor is yours.
I'm going to try. Good morning, ladies and gentlemen. My name is Bridget Namoviru. I work with Mengo Hospital as a quality improvement officer, and I'm here to present to us. I am here to present to us on a rapid project that we did on improvement on oxygen availability and efficiency among patients at the COVID-19 treatment unit. Those listed below were my co-authors, the team that I worked with. Okay, a brief introduction. As we all are aware, COVID-19 in Uganda stood at nearly 93,000 with over 22,500 deaths, and 1,062 of which were recorded between June and July of 2021. And oxygen is an essential medication for treating acute hypoxemic respiratory failures, like in COVID-19 and in pneumonia. That was stated by the World Health Organization as of 2021. So we were lucky in Mengo to be accredited as a COVID treatment unit. However, we did face quite a number of challenges, but the leading challenge was availability of oxygen in the unit. And most of the deaths that we experienced in the unit were attributed to oxygen stockouts, something that I'm sure we experienced in some of our units. So our project was focused on improvement on oxygen availability and efficiency for better management of COVID patients at the Mengo COVID treatment unit. And at the time we were experiencing a death rate of about 25%. So we hoped we would reduce it by 10% with the intervention that we had thought about. And what did we do? We decided to establish an oxygen manifold at the unit and piping it to enable access of oxygen at every unit in the oxygen treatment unit. So someone would ask me, what is a manifold? That's our COVID treatment unit, but when someone asks me what's a manifold, it would basically look like that. That's a basic manifold. It's like a centralized place where oxygen cylinders can be connected to the piping, as you can see. And these tubings would be connected all the way down to each and every bed, as you can see. So every bed in the unit that we had, we did connect the tubings so that a patient could access oxygen through those tubings. So from the methodology, of course, we had a problem analysis so that we could brainstorm with our COVID-19 response team. We scheduled regular meetings to be able to coordinate. And then, of course, we wrote a proposal to management. Then we established an oxygen manifold. And then, of course, we had to train the teams that would be able to operate the manifold. And then we also had a series of collection of data. And finally, we did have an analysis of our results. Sorry, my screen is off, but okay. Okay, so from the months where we did collect data, initially, we realized that, like I said, we were at 25%. That means that for every 4 persons that we did receive in the unit, 1 did die. And when we established the manifold, we actually experienced an increment. We experienced an improvement where we had a drop from 25% to 12.5%. That is like minus 12.5%. So we got to a point where for every 8 persons that we did have, 1 did die. And this was attributed to the oxygen manifold. So from, like, I've just explained the results, but from what we realized is that basically, like I hope we've all experienced in our facilities, we would have a scenario, for example, where you would have probably 8 patients and they all needed oxygen. But then you have like 7 cylinders. So, and then you would have to connect to the 7 patients, leaving 1 to probably be saved by God. So when we established the manifold, it sort of created a platform where there was shared usage because oxygen was connected in a central place, and then through the tubings, the patient will be able to share what was available. So we were able to utilize the little resources that we had to serve every patient. So this means that all the 8 patients will be serviced with these 7 cylinders while the team figures out a refill or something of a sort, which sort of improved our service delivery. And like I said, of course, it played a role in reduction in the possibility of losing a patient, because most of our patients would be lost while we are trying to change the cylinder and put another one, and then they would desaccurate. So because the manifold is a centralized system, and if we've looked at the pictures properly, it has a left arm and a right arm. So usually, well, if the left arm is used up, we would swap to the right arm while you refill the left. So it also helped us stabilize the availability of oxygen in the hospital because there was a centralized monitoring of the manifold. We were able to establish a stable system of actually availing oxygen for the patient. So some of the lessons that we learned were that, like I've explained, it helped us in a great deal of increasing accessibility. I've just given us an example of the 8 patients, and probably you have 6 cylinders. And then it also, we noticed that it played a role in reduction of infection because these oxygen cylinders are the same that are used in different wards of the hospital. So if we have a centralized place where they are placed, now for example, we would have to remove some of them from the COVID unit and then they will be taken to the NICU or they will be taken to the ICU. So because we established a centralized place for these cylinders, it played a role in reduction of infection spread. But also we did realize our patients were less anxious, especially because most of the patients would get anxious if they saw you connecting them to a cylinder. So it helped us in that way, but also we learned that weekly monitoring and teamwork and feedback in the team contributed a lot to our quick adaptation to the change in the COVID response. In my conclusion, oxygen manifold does really play a role in increasing availability and efficiency of oxygen in health facilities, and I hope that those that can would actually adapt it for preparation of the future or for even now, because oxygen is not just needed in the CTUs. And I would like to acknowledge the following people for playing a big role in us achieving what we did achieve, and thank you for listening to me.
Thank you very much, Dr. Bridget Namubiru, for that wonderful presentation. And again, showing us that innovation is really work. I don't know why the name manifold, whether that is the WHO recommended or you could call it any other name, but definitely this was a good innovation that helped, avail oxygen to the COVID patients. And again, reducing the anxiety, because those cylinders are not fancy. They are not good. Seeing connecting cylinders, then disconnecting, connecting another one. So if they only see the tubes being connected, I think that was a wonderful innovation. But you will tell us where the word manifold came from, so that we use it properly. So again, if you have any questions, I hope you are taking note. We shall have a few minutes for discussion. I now want to take this opportunity to invite Adiau John to come and make your presentation. Please introduce yourself, and I don't know whether I'm pronouncing your name right, Adiau John. And thank you, Bridget, for keeping time. So all my presenters so far have kept time, and I'm sure you will not be the exception.
Okay, thank you, Chair. John Ediao, my name, from Kabale Regional Referral Hospital. I'm here to present an abstract on the impact of choice So it's just an eye opener. That's what I'm going to pass through. Yeah. So slide 1, I'm not seeing it. Okay, that's the title. So impact of culture and sensitivity pattern on the choice of antibiotic use in the management of patients at surgical ward in the Kabale Regional Referral Hospital. The displayed are the authors as seen. On the background, at Kabale Regional Referral Hospital, especially in surgical ward, broad-spectrum antibiotics are prescribed for patients irrespective of the duration and the nursing care given. It was found that there was no improvement of some patients upon antibiotics used, which led to long stay of patients in the ward, hence increased cost and increased number of patients in the ward, and which would pose a high risk of COVID-19 spread due to congestion. So initially in surgical ward is a ward that handles conditions like fractures, wounds, burns, ulcers. You can really see the number of days these patients are likely to take in the ward, and with the improper management, there is likelihood of long stay of patients in that ward. Okay, the slide is not moving. IT, the slide is not moving. Okay. Among the root causes that the WIT team sat down and discussed, what could be the causes of this patient's long stay in the ward? They came up with a number of reasons as members discussed the issues and the way forward of managing this type of incidences in the ward. One of the causes they came up with, one, there was inadequate utilization of culture and sensitivity microbiology, inadequate utilization of infection prevention and control practices like hand hygiene, and of which currently it is still a burden to the whole regional referral hospitals and even the lower health facilities. Torn mattresses, which harbored resistant microorganisms to some of the antibiotics, among other causes. Next slide, please. Okay. Next, yeah. So the method that we try to implement to look at to solve some of these issues. One, using the root cause analysis and try to implement some of the countermeasures. One, we try to sit down in work improvement meetings to come up with an action plan. That is to try to come up with solutions to solve this issue. One, antimicrobial resistant related meetings, which we conducted, taking off pus swabs from infected wounds and also around the surrounding of the patients, which included the patient's beds, wheelchairs, and we shall see what happened in the results. CMEs, health educations, isolation of patients, dressing of beds with the new mattress covers, and general disinfection of the ward, among other measures. Okay, this is one of the beds that we had in the surgical ward. As we can see that bed, how it is, and assume you are patient or relative and you have escorted to that ward and you see that kind of mattress they have given to you, you'll have your questions for yourself. So there is a meeting conducted to solve some of these problems. Two, we tried to disinfect the ward and also including the mattresses. The torn ones which were put new Macintoshes, as you can see. Those are just ward staffs helping the cleaners to do the job. These mattresses were disinfected, sun-dried, and also later put new mattress covers. Taking off the pus swabs, or rather taking off the swabs from the beds. And later we shall see on the results what we found in these beds among the nursing care given to the patients in the ward. On the results, including all the antibiotics set apart from imipenem. Acinetobacter, that is a brief, let me give a brief definition of Acinetobacter. It's a microorganism that is opportunistic microorganism that is able to spread within the hospital environment and mostly on hospitalized patient. 3 Acinetobacter species were isolated, one from urine and other from swab, others from wound swabs, from all patients that were admitted. After 1 month, 41.7% of the swabs taken from environmental swabbing had Acinetobacter, while 58.3% were other environmental what? Microorganisms. So as you can see there, we try to use these antibiotics, but we forget the environment of these patients. You can ideally remember or recall, if you have gone to a medical service and somebody says you have this drug or prescribe this drug to you, and again you say, but no, doctor, this drug doesn't work on me. I believe if you have not witnessed, you must have ever had. So those are some of the causes, and we take these drugs unknowingly. So here is the table and a graph below. So as you can see on the first column, is a specific site taken, that is on swabbing. We are seeing there are also patients' beds, wheelchair. Yeah. Then on the others, the specific microorganism that was isolated. And here we are seeing much of Acinetobacter species identified. And those are some of the antibiotics that were tested. We have ceftriaxone, that is CRO in the key. We have ciprofloxacin, that is CIP. We have SXT or COT, that is cotrimazole. We have gentamicin. We have piperacillin, tetracycline, imipenem, cefuroxime, and amoxicillin clavate acid. So in the graph here, as we can see, we have a blue color, then we have an orange, then we have a gray one. So if you look at IMP, that drug, it was the only drug which was not resistant to this microorganism. And if you look at imipenem itself, it is not found in our hospital setting. It is an expensive drug to buy, even of patients. So what did we do? We encouraged these patients to buy this drug, since we were not stocked in the in the hospital, and this drug is very expensive for management of this microorganism. So the lesson learned: there is need to implement antimicrobial resistant stewardship program, and you need to develop hospital guidelines within the hospital to reduce further prescriptions of broad spectrum antibiotics. I can give an example. If a patient came to you and had maybe a UTI and is prescribed, give IV ceftriaxone 2 grams start, and maybe ciprofloxacin or rather metronidazole, and not knowing what is the right drug for this patient, which microorganism specifically is this patient having. So in the long run, the patient ends taking up those drugs. Besides, they will not work. Yeah? They might not work, but the patient is taking them. And next time again, you're going back with the same issue. So we need to utilize the culture and sensitivity to really identify the microorganism present and treat it correctly. I acknowledge Minister of Health, JICA, IDI, Hospital Director, Kabale Laboratory team for the timely work that they did, helped in culture and sensitivity, and staffs of surgical wards. Thank you for listening.
Thank you very much, John. I think that was also an eye-opener, that quite often we are just giving antibiotics when we are treating ourselves, not the patient. Because just prescribe broad-spectrum antibiotics, but they are not working. But again, doing culture and sensitivity is not cheap, even for regional referral hospital. So that's the dilemma we have. Anyway, thank you once again for the presentation. Let me not preempt questions for the discussion. So we have, and thank you, my presenters, because you've presented in time, so we have a few minutes of discussion before we go for lunch. So if you have any question, please raise it and tell us to whom you are raising the question. Your hand is up, I imagine. Is there a microphone, or I don't know, the organizers, is there a microphone for people who have to shout? Yeah, I think there is a microphone. Give it to that lady. Put up your hand if you have any comment or question. And please tell us which speaker you are directing your question to.
Yeah. Thank you very much, our speakers. I have two questions. The first one goes to Madam Nambiru, I think the one from Mengo Hospital. I thank you for that innovation. I'm just concerned about, okay, you are able to avail oxygen to all the patients, but I'm concerned about the volume of oxygen the patients are receiving, because some of these patients at one time needed a lot of oxygen to be flowing at a faster rate. So how was that manifold able to deliver oxygen at a faster rate? Especially, they have different needs at one time. I mean, you may find one patient doesn't need a higher flow of oxygen or more volume of oxygen to flow, and then another one needs less oxygen. How are you able to ensure that the flow of oxygen is tailored to each patient's needs? Because to me that is of concern. If you make it go through the manifold, some people needed a higher flow of oxygen, especially when their lungs were more damaged than the others. So how did the hospital go about that as well? And then the second one is to the gentleman who was just presented about the last presentation. Thank you for reminding us that we need to do culture and sensitivity. I just wanted to say the availability of culture and sensitivity tests remains very low in the country. Even many labs don't do it. Actually, there are times when I've taken off samples and they've not done it. Many labs don't do it. So I was wondering whether there are cheaper methods of doing culture and sensitivity other than culturing itself that can help us know, or we still have to go through that traditional culture and sensitivity. But most of the time, it is harder to do it, and people don't do it, and they just look at the most broad spectrum antibiotic to give to patients. Thank you.
Thank you very much. I think we take more questions. Let's first finish that side. I'm coming that side.
Yes, thank you, the moderator, and thank you, the presenters. My name is Dr. Kaita Godfrey. I'm an epidemiologist with the AFINET. My question goes to the malaria presentation, and I'm looking at the recommendation of mass community treatment of asymptomatic malaria cases in order to lower the prevalences of malaria in the community. And I'm looking at two aspects. One, I want to get a feel of what was the cost, or what is the cost of doing this massive treatment in the community. And two, we have always known that a certain level of flowing parasites in the blood of individuals could prevent severe malaria. So if you went ahead and did this massive treatment and you got us rid of our levels, and that is our herd immunity in this community, we have built it. That's why we are able to resist this malaria better than people from the Western world when they come here. What would be the cost of management of that severe malaria in case those cases start coming at our hospitals? Thank you.
Thank you very much, Kaita. Is the presence of parasites the one that protects us, or the immunity that we have developed to the parasites? But that question will be answered by the one whom you asked. Next.
Thank you very much. I want to start with Fabi. I want to understand how you conducted health education at those facilities to improve the 50% gap. And then you stated that to improve on timely calling, you are using the relation between patients and the doctors. Don't we use the peers? Or we don't have the peers to run to help this? Because I'm very sure doctors are always very scarce to do this work. Oh, you are meaning the health workers. I'm very much happy on that, on Mr. Edward's presentation on the malaria upsurge I happen to come from those districts, and I saw that activity working very well. However, I was asking about the VHT inclusion for the sustainability of that upsurge activities. And then on Dr. Bridget of Mengo, I think the first discussion has talked about it on the volume of oxygen. I was also thinking on the volume of a patient to receive, or is there some kind of installation per patient to regulate the volume of oxygen per patient? Thank you very much.
Thank you very much. Now we come in the middle. Anyone with a question or comment in the middle? No, we should finish that side. Let's come this side. Time is not on our side. There was a gentleman that side. Yes. Take the microphone that side. We still have maybe 2 more questions, and then we shall request the presenters to respond. And I hope by that time we should have earned our lunch.
Thank you very much. I'm Sadayo from Liantonde, and my question goes to Henry Jackson Ogwal. Henry Jackson Ogwal, when he introduced his topic, he strictly went on minus telling us the key terms. To some extent, some of us got lost when he started introducing RAS. Maybe in the Dokoro district, they use the RAS systems, whereas maybe in the central and probably western, there is an M-track way of reporting things. So, to some extent, some of us got lost. He was supposed to define the key terms. Then, the question still, I wanted to know what is the mode of verification of the accuracy of the reports that they collect. Could there have been any audits that may be quarterly audits or monthly audits on the facilities? Because I realized when I used to do some reports, collect reports and collecting data, there was no correlation of the M-track or weekly reports with the monthly reports. So what was the mode of verification? I expected to hear that. Thank you very much.
Recording in progress.
Thank you. There is one, last one, then we shall have one from Zoom. Online, our colleagues online.
Thank you, Chair. I was requesting for guidance. Is it possible to ask the presenters who presented online, Dr. Duralian?
No, that was a different session. But you can write your question, give it to the Secretariat. They will make sure that question is answered maybe. Okay, can we have the one on online on our screen? There was a question online from Zoom. Can it be? Can I request the presenters to come in front so that we answer these questions and we finish? The presenters come in front, we answer the questions and then we finish. So Mafabi, you have one on the screen. I hope you are taking note of it. One of the factors affecting developing uptake among the HIV-exposed infants is non-disclosure of the mothers. How did you overcome this? Okay, so I hope the seats are enough. I start from my extreme left. start by answering the questions and then we shall finish.
Okay, thank you. Good afternoon. Thanks for this opportunity. I'll begin with the one for the moderator, which he asked me at the moment I finished my presentation. He said, how sustainable is the phone calls? We are a service provider. We have funders who avail to us some of these. We suggest to them our strategies to achieve the targets that PEPFAR needs, and they provide us with those funds to have the phone calls done. We are sure all healthcare workers in Uganda have at least access to a phone in Uganda. All healthcare workers have access to a phone. Maybe the issue would be the airtime. IPs can best address that. But for us, through UPMB, we have always had the access to the airtime. Then my brother from this side asked, how did we come up with a 50% gap? Usually, when you are doing a study or a HUI or doing any research, you have to have a baseline of where you want to begin from. Some of our strategies we started with, like cohorting. We started with it earlier on before even we took up the CHUI. So in the cohorting of the pregnant mothers, according to their the age of pregnancy, and also the EDD, we had already started on it. So it is from our source document, the improvised register, where we got that in the month of March, it has been worst hit. We have only 50% of the children who have had access to the Nevirapine. So we started with the cohorting. We got our baseline from our cohorts we had previously. Then he also asked about why did I say doctor-client relationship? I use that word connotatively. A doctor does not mean a medical doctor alone in English. A doctor, in the sense of a client, is someone who is giving care to him or her. So I used it connotatively. I didn't mean only doctors call. Me, myself, I'm a clinician. I'm not a medical doctor. But I put myself in that connotatively. We have a big, as TASO, we have a big healthcare force. We have from peers to mentor mothers and expert clients. They are healthcare givers. So all of those are what I call doctor-client relationship. Then from online, we made mention, the question was asked about disclosure. Usually, through the 9-month course of the pregnancy, we make sure on the EID card, for those of us who have had an interface with an EID card, there's a section where a mother is encouraged to disclose to the partner. And if it is not done so, we make effort to help the mother disclose. So disclosure is one of our least problems as of in TASO Mbale. It is one of our, it is there, but still during the study we didn't encounter it. That's why I didn't make mention of it in our CHUI project. Thank you.
Thank you. Rebecca Nekaka. I'm answering on behalf of Edward Mugwanya, whose presentation was audio recorded. Yes, so the question was on the cost of mass treatment. Just to mention that under the program, under Rights North Lango, malaria program and malaria prevention and treatment is one of the areas that we are focusing on. And we had mainly the funds we put in were for the community outreaches and reaching out to these people. But the treatment, the usual support given to the facilities, I think in the past few years we have been well stocked with SCTs. It has not been a big challenge. So the clients who tested positive were being referred to these health facilities or be getting treatment with support from the health workers who were coming from these nearby health facilities. Yes, of course, looking at the cost and sustainability, that may be something that needs to be discussed, but if it's going to give us results, then it's worth investing in. Then the concern of malaria, if people are symptomatic and its relationship to severe malaria, I think having parasites per se is not what makes us resistant. It's the immunity we develop from the continued exposure to these parasites. If you look at the natural history of malaria, if we go back to epidemiology, is that you have an infection, and if nothing is done, you progress to a symptomatic state, and then you progress to uncomplicated malaria, and then severe malaria and death. So we always want to intervene along this cascade of the natural history of this process. So if we are not able to prevent the infection by the use of the mosquito nets and all these other methods, if someone has been infected, then we want to see what is it that can be done. So that is why the thought of if we are able to identify these asymptomatic cases and treat them, then the chance that a mosquito will bite this person and transmit malaria to the next person is limited, instead of waiting for them to present in hospital with symptoms, signs and symptoms of malaria. So it's something that we are recommending, and there would definitely need to be an evaluation on whether it's possible, do we have the resources to do this? But I think instead of waiting for severe cases of malaria, it would be good to actually interrupt the process at this point. Thank you.
Okay, thank you. I think I've received so far now 3 questions, and one of them was from the chairperson of where does the word manifold come from? It's a biomedical term. I wish there was a biomedical engineer to describe it for us, but in simple English, a manifold is basically a pipe or chamber that branches into several openings. So I hope I've answered your question. And the other question I got were about management of flow and volume for patients. So first of all, the nurses would regulate oxygen as prescribed. Like we all know for patients that have pneumonia or that need oxygen, not everyone will need the same volume of oxygen. I don't know if we know, someone asked me the question from that side, and I don't know if you have seen something that they call an oxygen flow meter. These oxygen flow meters have different mils. So basically, they are measured in liters per minute. So we had a number of them. We had the 15 mil, we had the 70 mil, we had the 20 mil, we had the 25 mil. So that's how we would regulate the flow. So based on the prescription for a particular patient, you would use a different flow meter for the patient. So
I think their concern was if they are using the same cylinder.
If they are using the same cylinder.
Each patient would have his own.
Like
we are used seeing the flow meter on the cylinder.
Well, I wish I could go back to my presentation, but like we saw, the piping, it goes all the way to the bed, and then there's that opening. So it's through that opening that you would insert an oxygen flow meter. So every patient had a different flow meter. Have I answered your question? She says I've answered her question. And I think I've also answered the volume question. So someone asked me from online, how we would manage breakages of the oxygen cylinders. I think that would happen in all facilities. But we did have, like I said, we did train a team, but also I want to say that we have a really good team. We have an oxygen plant on site. So we did have a team that was well equipped knowledge-wise. So this is a team that also trained the people that were manipulating the manifold. So of course we would have a few breakages here and there, but those were also very minimal because we had a really experienced team managing the manifolds. I hope I've answered our questions. Thank you.
Thank you very much. I'm answering my colleague. First of all, the question was about definition of terms of the RAS. As we all know, HIV and TB services is very dynamic. And each time there is a change either in policy, and this affects the efforts needed to ensure that the required commodities are there. And this would require that when the new intervention or the new policy is coming in, there is a great need for monitoring of the supplies. Because most times, the supply also, when it's at the beginning, you cannot have enough supply. So the ministry came up with the intervention that can we see how to easily get visibility of the stock status in order to support this dynamic change in HIV and TB services. Recently, we have heard about transition to TLD. We have heard about optimization of children. We have heard about TB preventive treatment, TPT.
I think you defined for him
MMD.
RAS,
Yeah.
because
So,
for them they are using something else.
so the system is called Real-Time ARV Stock Status, RAS. This was also coined by the Minister of Health. So because it did well with ARVs, they brought in TB, they brought in test kits. So RAS is used the same way across the regions in the country. It's not only in Lango region. It is for all ART sites in the country. We choose it as an option because COVID challenged other methods of monitoring stock status. About the verification of accuracy of these reports, yes, we have systems to do this. First of all, this is a weekly report. We are able to access the absolute figures reported, and I can track a particular commodity on a weekly basis and see how the facility is consuming. Secondly, we also innovated monthly stock status verification at all the ART sites, where all the other ARVs are also verified in terms of quantities, consumption, and expiry date, so that when we sit at the end of the month, we are able to take action that will avoid wastage through expiry, and also bridge the gaps of stockers and low stocks, especially like the month-to-month dispensing now. Thirdly, we also have the facilities providing reports on a bi-monthly basis. We try to triangulate this to see if the reporting has been flowing well, because at the end of it all, it is the same facility reporting about the same drug. So this gives us options of trying to verify if the data that was being provided is correct. In case of any problem, we make a visit to such a facility and go deeper into the issues. I hope this answers the question that was asked. Thank you.
Okay, I'm glad I'm always the last, yeah, but I want to answer a question of availability of culture and sensitivity at Kabale Regional Referral Hospital. One, sustainability follows competence. So at the Kabale laboratory team, they are trained, fully trained on the use of these culture and sensitivity machines. I want to take us back. The lab structures and the procurement systems in other hospitals, you find that they have these machines. They are stocked in stores. Staffs are there. They are not trained. They are not competent on their use. Patients need them. Now, at Kamal Hospital, normally they hold weekly meetings on looking at how best can we serve the community, what best can we prioritize to make sure the service is consumed and utilized by the patients. We also have support from the IPs when we get stockouts. And also, as one of the hospitals in far southwest Uganda and serving a large population, there is always maintenance team for these machines whenever they go faulty. So this actually brings the availability of the service and cultural activities performed on request and results availed. Thank you.
Thank you very much. I think another round of applause for my presenters. They have been very, very wonderful presenters. Thank you very much. And if you don't mind, you can also clap for the moderator because he has also done a wonderful job. And I wish you a wonderful lunch. So we go for lunch and we come for the next session in the afternoon at 1:30. Thank you. Okay. The session is adjourned.
Good after lunch. Some people want to say good afternoon. I would love to call the presenters to the stage. Alert me when you want to start. I want to invite all those who are intending to sit with us. It's a Friday afternoon, and if we all got seated quickly, I'm sure we'll be able to hear the very interesting afternoon. This afternoon we have a panel discussion of 4 people going to present to us, very eminent scientists and managers, and we have 2 people in the room and 2 will be online. Our first panelist is Dr. Dithan Chiraga, and the topic is strengthening infection and prevention control interventions at health facilities. Dithan is currently the Chief of Party for Rights North Acholi. He's a medical doctor and a public health specialist with vast experience working in international affairs, industry, Africa, Asia, and of course, Uganda. Dithan has been coordinating the Rights North Acholi as a technical team that is supporting the COVID response in Acholi region. Ladies and gentlemen, join me as we welcome Dithan to start off our discussion this afternoon. And the topic of his discussion is strengthening infection and prevention control interventions in health facilities. Dithan, you're welcome.
Thank you, Chair. Good afternoon, everybody. I know it's been a tough week. Bear with us. We are having the last session for the week. Chair, there's still a bit of noise in the background. First, I want to congratulate and thank the organizers for the 8th Annual Quality Improvement Conference. To thank you for a job well done. Rights North Acholi is privileged to be associated with this Quality Improvement Annual Conference. The topic for my discussion this afternoon is around strengthening infection prevention and control at health facilities, which has come to the front with the advent of COVID-19. No one should get sick while seeking healthcare services, and no health worker should contract disease while providing care. Yet we know, despite advances in healthcare and patient safety, we continue to see hundreds, if not millions, of both patients and healthcare workers falling ill in the course of accessing or providing care. Health facilities, healthcare settings have become ideal settings for transmission of these infections, the healthcare associated infections. You heard this morning a presentation from the former chair of the Uganda Medical Association, the statistics that he presented to us. At some point, chair, we're losing close to 4 doctors every week for a period of almost 5 weeks. Obviously, some of these infections could have been acquired in the community, but we know that there's always risk within the settings that we operate in. Just this week, I had a colleague, one of my staff, she took her sister to a healthcare facility to have a basic surgery, a cesarean section. Following the C-section, there was infection, peritonitis. The sister went into renal failure, and she was admitted in the intensive care unit. She seems to be pulling out, but the result of this is that you find that she's going to have a longer stay than envisaged within the healthcare facility. There are issues around complications and the long-term impact. And obviously the costs are going to be higher. Statistics show that close to 10% of patients who access healthcare settings do acquire infections in the process of accessing these services. And we know during the COVID period, actually, a number of our healthcare facilities were shunned by the patients due to the fear of contracting COVID. The issue is a subject of numerous litigation, and also some of the strikes that we are seeing even within the country as people try to appeal to better healthcare settings and work environments. Now, obviously, with the advent of COVID, the issue has come to the front. There is more attention. A lot of governments, the Ministry of Health has tried to review and update the National Infection Prevention Control Guidelines. And these are really practical, evidence-based tools with information on basic hygiene, infection safety, waste disposal, and use of PPEs. These guidelines, they are available. They describe the structures that we need to have in place, the teams that need to be available for infection prevention and control, and they need to be regularly updated. Also, there is now a move to make sure that the curricula is integrated in pre-service and in-service training. Now, we've had a number of partners that have come in to support the national efforts towards strengthening infection prevention and control. USAID has come in strongly. We've been heavily supported by the US government to support district and community efforts towards infection prevention and control. We also have a number of partners. Obviously, WHO at a global level is leading these efforts. The number of publications that have been produced by the World Health Organization, the Centers for Disease Control, CHAI, many of these partners have actually supported national efforts through provision of resources. And we also have evidence that some of these investments have huge impact in terms of reducing these healthcare-associated infections. For example, we know that hygiene improvement efforts do reduce close to 50% of the healthcare-associated infections. Now, in strengthening health systems for infection prevention and control, it requires a multidisciplinary effort across the WHO building blocks. You have to look across the entire cascade. In terms of healthcare service delivery, you have to look at the entire infrastructure at a health facility. You look at the health workers, the patients who are accessing these services, and some of the things that, as Rice North actually, we've supported the districts and the facilities, PPEs for the healthcare workers. We provided training, tools and guidelines, not just to the health workers, to the lay workers, to the community volunteers, also the local governments. We've strengthened IPC within the healthcare facility by pushing for double masking for the healthcare workers, making sure the patients also have and wear their masks while accessing these services. We've strengthened hand hygiene practices. We promoted social distancing, proper sterilization. We've promoted safe waste management. And also, we've supported activities towards institutionalizing QI through the creation of various collaboratives for quick learning. We've promoted low-cost innovations for IPC and WASH services. And also for cases where we've seen shortages for the healthcare cadres, we've strengthened, promoted task shifting, making sure that other cadres do have relevant skills to strengthen IPC. We've supported activities towards health information systems. We know it's really critical to make sure that the tools are available, data is collected, there's surveillance of cases, there's community engagement, there's risk communication strategies, and also to ensure that there's readiness for IPC across all the health facilities within the sub-region. There are issues to do with availability of essential medicines, drugs, supplies, and also the vaccines. I'm happy that healthcare workers were considered as a critical category when we first got the first batch of vaccines within the country. You need to make sure that medicines are available in cases of exposure of the health workers. Issues to do with health financing are also critical because the cost of treating a number of these healthcare-associated infections can run in millions of dollars. So we need to make sure that funding is available to support IPC activities. And you can leverage some of the existing resources. PHC funds can be critical, and we need to make sure that some of the allocations go towards IPC activities. And finally, in terms of leadership and governance, we need to make sure that there's leadership available at the district level, both the local government, the technical wing are supported with the necessary skills, and that they continue to oversee and support IPC interventions. Over to you, Chair. Thank you so much.
Let's clap for Dr. Chiraga. Thank you for that presentation. I am going to invite the next presenter, Dr. Susan Nachireka Tumwesije. And the topic she's presenting is non-communicable diseases control in the era of COVID-19. Susan, please come up this way. And allow me to give you a little brief about Susan. Susan is currently the physician at Mengo Hospital and the board chair, Uganda Non-Communicable Disease Alliance. She's also a board member of the East African NCD Alliance. She's a senior lecturer at Uganda Christian University School of Medicine. And she's also a COVID-19 CTU physician at Mulago Hospital. Susan is a principal investigator at multi-center studies on determinants of COVID-19 outcomes in Uganda. So join me in welcoming Susan. Susan, you have 10 minutes to present.
Okay, ladies and gentlemen, I take this pleasure to thank you for asking me to speak at this conference. I'm going to speak on the other side of diseases that are affecting us, that is non-communicable diseases. I'm speaking as a physician who treats NCDs, but also on the side of civil society organizations. So it's an opportunity to speak at a meeting like today, where most of our talks have been based on infectious diseases. So UNCDA, which is an organization I'm representing, is a partner with Ministry of Health in the fight against NCDs in Uganda. We've been in existence for over 10 years. And we run our activities in 10 district branches in Uganda. And we are a member of the East African NCD Alliance, which brings together alliances from countries in East Africa, 6 countries. We are also a member of the African NCD Network and Global NCD Alliance. We have several achievements. We supported the formation of the Uganda Parliamentary Forum on NCDs. We advocated for the Ministry of Health NCD department, and we are seeing it growing. And we carry out a lot of activities within the health care system. We train health workers, we screen, we provide medical supplies, and we've also supported people living with NCDs. So why are we talking about NCDs today instead of infectious diseases? These are diseases which are growing in number, and persons suffer for a long period of time, and they result from a combination of genetic, physiological, and environmental and behavioral factors. They kill 41 million people annually, which is 71% of deaths globally. And importantly, these deaths occur mostly in low and middle income countries where Uganda falls. Most of these deaths are premature deaths. And the commonest 5 NCDs include cardiovascular disease, respiratory disorders, cancer, diabetes, and mental disorders, but there are also others. The 5 key risk factors include unhealthy diets, tobacco use, physical inactivity, air pollution, and harmful use of alcohol. So in Uganda, the 2014 survey revealed that alcohol consumption is still high at 40% in men, and very importantly, people are consuming unhealthy diets at 88%. And diabetes prevalence is at around between 0.4 to 9%. The commonest cancer in women is cancer of the cervix, and men is Kaposi sarcoma followed by prostate cancer. Mental disorders account for 3%. So if you look at this, we see that deaths attributed to NCDs are almost the same in the East African region, with Rwanda affected having the most deaths, followed by Uganda. And we noticed that the percentage deaths increased between 2017 and 2020. And what is driving this NCD burden is importantly rapid urban, unplanned urbanization. People are living sedentary lifestyles and eating unhealthy diets. If you look at this picture, you notice the kind of streets we are walking in. You can hardly move through such streets, and people are literally couch-bound and eating unhealthy foods and gaining weight. And this is affecting also the children who are equally eating unhealthy fast foods. And this is a typical plate in a local food restaurant, but you notice there are hardly vegetables and huge sums of carbohydrates. And environmental factors are also contributing to NCDs: air pollution, indoor air pollution and outdoor air pollution, secondhand smoking, but also diets low in fruits and vegetables and high sodium intake. So you look at this picture, you see the kind of cooking we use, and also the environment we move in, exposing us to NCDs. And people are living in slums. And of course, slums come with also their problems. People at risk of both non-communicable diseases and communicable diseases or infectious diseases. So we want to see people eating healthy. Though the healthy foods are expensive, we need to see people cutting down on sugar, on fatty foods. We need to see people eating fiber. And we need to see people using smoke-free cooking. We need to see towns with walkways. We need to see children having play space. And we need to see people being able to walk to work. So before COVID-19 came, NCDs have been there. Patients present late with multiple complications. Diagnosis is delayed. These are patients who are chronically ill. They lack self-monitoring tools. They are poorly controlled. They move long distances to the clinic and end up going to a nearby clinic. They are always absent from work. And at the clinic, there is no privacy. The costs of treatments are high because they resort to going to the private clinics with expensive drugs. So they end up in traditional healers' hands and other alternative medicines. They are not able to afford the healthy food alternatives, and they suffer a lot of mental distress. So this is the kind of picture we see in our NCD clinics. And of course, the healthcare system is not ready to take care of these growing numbers of patients. They are short of trained health workers. There are few staff who are handling the congested clinics. The staff are congested, and there is not enough NCD clinic space to manage these patients. Medicines are not enough. Most of the patients receive medicines for only just 2 weeks, and yet they are told to come back 3 months later. And patients do not receive sufficient patient education. And our legislators are not doing enough. For example, it is seen that Minister of Health in this study in 2020 was playing more of a supportive role, supporting other organizations in implementing these policies that they should be actually ahead of. So these are the kinds of clinics we see. A crowded clinic with just one doctor, 2 nurses, with no privacy. So you find that 3 patients sit in one room to see a patient. So when COVID came, it exposed the gaps in the healthcare system. Of course, we saw that patients with COVID-19, with NCDs, were more at risk of severe forms of COVID-19, and most of the patients who died of COVID-19 were NCD patients. And these are, we noticed that during this time, the clinics closed off, and NCD services completely were closed off. For example, in this study, you notice that most of the deaths were due to NCDs. COVID deaths were occurred in patients who had NCDs. And WHO report 2020 revealed that there was interruption of NCD treatment across most regions in the world, but the
2 minutes.
low-income countries were affected most. I'm about to finish. So we need to see that measures to protect clinicians and staff are put in place during these times. SOPs, for example, hand washing, PPEs. We need to decongest the clinics. We need to resort to open air education, vaccination, and others. But very importantly, we need to see increase in financial resources for health so that we are able to improve healthcare service in our NCD clinics. Ladies and gentlemen, such is IEC materials which were given to patients with COVID-19. We need to see our patients receive such IEC materials that they can refer to in case they are not able to reach the hospitals. I want to recognize Minister of Health NCD department. I saw our Commissioner, Dr. Gerald, here, whom we've worked closely with, and also the Danish NCD Alliance, who fund our organization, and also others. Thank you so much.
Thank you, Susan, for that wonderful presentation. I'll ask you to sit up here. We do still have 2 more presentations, but I see the number is beginning to drop. That's why I was cutting her time short, so that you don't all disappear before we present. Susan, you can have a seat. We have 2 other presenters online. Unfortunately, we will want to take all the presentations at once, and then we have a common discussion. We have Dr. Rhoda online. Is she there? Professor Roda?
Yes, I am online. I hope you can hear me.
Yes, I wanted to introduce you before you speak, and online is Professor Roda, who is currently the Dean of School of Public Health in Makerere University. She's a medical doctor and a renowned researcher. She's also a member of both the COVID Scientific Advisory Committee and the COVID Vaccine Advisory Committee. Dr. Roda, please, can we have your presentation? We have 10 minutes for you.
Okay, thank you, Dr. Chabainze. I appreciate the opportunity to share my quick thoughts. I've heard you talk about time, so I'll try to be very quick. I was asked to talk about the role of implementing partners in strengthening the health system, in building the health system. And I'll just mention a few concepts in the interest of time. But to begin with, I will say that we have come a long, long way. Thinking back the many years that I was part of the HIV response, about 20 years ago, when we were beginning a lot of the programs that I was involved in myself, the history is longer, but I'm speaking about my own journey. And thinking about the times when we were funded to implement HIV programs, and you had to justify very strongly to do anything outside HIV. You had to justify very strongly to talk about health systems. We started with treating people, and then we thought we needed to have a good system to treat people, to deliver the drugs, and then we kept expanding until we have slowly moved to the broader health systems building blocks. But along the journey, we realized before this shift that we cannot achieve the outcomes for HIV without looking at the broader health system. We also started then thinking you cannot treat someone for HIV and they improve and then they die of malaria because you didn't think about malaria. And then as we improved the survival, we started thinking, okay, so they are getting non-communicable diseases. We need to integrate this. So we've done a lot of reflection, and over time, we have moved away from very parallel thinking in terms of diseases into thinking the multimorbidity and also thinking across the lifespan. Although that thinking has taken root, that we need to be thinking about multimorbidity and that perhaps we might be more efficient if we address multiple conditions concurrently. Our plans, our policies, our implementation have not really shifted so much. And I'll mention just a few things. So this journey continues. We've made a lot of progress and we need to appreciate our partners that have supported us to make this shift, but we still need to do a lot. And I'll mention a few examples of this. We have also now started increasingly thinking, and COVID has pushed us even further down this journey, that we can't just have health within health sector. We need to be thinking about health outside the health sector. As we have seen, whatever we do in health affects other sectors grossly, and whatever happens in other sectors affects us grossly. And it's not something entirely new because we do have the sustainable goals and the framework that shows all the interlinkages between the sectors, but we haven't really moved as far as we ought to. So we still have quite a number of challenges that we need to deal with so that we can look at health in a broader sense, health outside the health sector, and also within the health sector, thinking more multimorbidity and also thinking more across the lifespan. So we still have quite a lot to do, but nevertheless, we have made a lot of progress. And I think this is reflected in what all the implementing partners are doing. I know we use that especially when we are talking about HIV, but we are doing the same with family planning programs. We are also increasingly thinking the same with the TB and many other programs. So when we think and reflect about what has happened. We now have many more partners addressing issues of the health system, many more partners going beyond the public sector to also look into what's happening within the private sector, especially the private for-profit that contributes about half of the services but has not received as much attention when we talk about quality and when we talk about issues of equity. But so we now have many more partners addressing this. We now have also partners working with the regional structures. The regional structures is one of the areas that has eluded us for quite some time, especially since we started multiplying the districts every few years and multiplying them so much that we can hardly supervise them. But we now have that structure, and several IPs have been supporting partners. And we also do appreciate that our major supporters, CDC and USAID, are now supporting these structures. But perhaps we need to do more to empower these structures and to also perhaps realign the roles of the IPs in supporting these structures as we continue to progress. We are now thinking broader public health and not just thinking infectious diseases, not just thinking HIV, not just thinking TB, although sometimes we also descend into arguing about which disease needs to be funded more than the other, coming from HIV to TB, and now we are thinking of eliminating malaria, and we are arguing about the same, and then also thinking non-communicable diseases, and we are still talking about what should be funded more than the other. But in a way, we are now beginning to think the broader public health, and I hope we can stay on that course. I can give an example of what we have been doing ourselves at the School of Public Health through the MEDS program that was introduced largely to support monitoring and evaluation, technical support focusing on HIV, and is now thinking in a more broad sense, expanding programs to support governance, leadership, and management for the district level, initially only focusing on HIV, but now broader, and also broadened the capacity building and support for information and data use beyond HIV to the broader health system, as well as thinking information systems and going to electronic systems in a broader sense. I really do hope that we will keep that going and expand that perhaps to also the most critical and immediate sectors that support health, and especially within health to the communities. I'll just highlight a few areas where I think we need to do more, where there are glaring gaps as far as I can view this. One of the issues that we need to realize is that we are not going to achieve universal health coverage unless we deal with the issues of health promotion and primary prevention. And most of these issues are really rooted in what happens in the communities. We have not done as much with community systems. We have not done as much in terms of engaging and involving the communities in health promotion and prevention. We also know that communities are very critical in chronic care, especially in self-management, but we have not done as much. So as we move towards self-care, whether it's for promotion and prevention or curative, chronic care services, we need to rethink the role of the community and community systems and how to make them encourage the IPs and our partners who support us, as well as the ministry, to also help provide a common framework within which we can work to fully activate the role of the community systems and the contribution of communities, individuals, and families. The other issue I need to also emphasize is we need to deal with the broader interlinkages with other sectors, thinking about health outside the health sector. And we need to integrate this within the framework of the health system and create those necessary linkages that can help us to turn off the tap in terms of disease. These are some of the issues that I think we need to think through quite carefully. What will that framework look like, and how can we operationalize it so that we can do better in terms of health promotion, prevention, as well as all the other levels of prevention? And then finally, as we think through the universal health coverage towards which we are all working, there are several areas we have not thought through carefully, and the definitions as well as the frameworks are not clear. One of those major issues is equity. Today we are having a conference on quality, but where is equity in the definitions, in the discussions that we are having? And if you want to think through equity and what has happened to us, you don't have to look far. You just have to see what has happened with COVID. I think the poor people are going to get poorer. The most disadvantaged people are going to get more disadvantaged. They are the ones that are going to drop out of school more. They are the ones that are going to struggle more with ill health. So we need to be thinking about equity. How do we view this? How do we define it? How do we track it? And how do we work towards mitigating and minimizing the inequities, especially that have been widened further by COVID? And then Sarah, perhaps this is her area, will talk more about this. The financial risk protection issues have become even more pronounced within the COVID era. How can we make this work for us moving forward as we recover from COVID and as we think about more resilient systems? So these are some of the issues that I think that partners can help with and work together with the Ministry of Health to make sure that we move this business forward. That the ministry can provide the leadership and give us the frameworks, but that we can continue to advocate for and support the improvements towards having a more holistic and comprehensive interventions to improve health systems, and for us to be able to think more about promoting health and not just treating when the health has failed. And as I end, I need to emphasize the value of evidence, the value of innovations, and the value of testing and coming up with new approaches. Because some of these things seem overwhelming when we begin to think about the broader health system, extending to the community systems and extending to other sectors. We need to put the eye on evidence, on finding what works, on piloting and expanding new interventions, and especially driven by leadership. Leadership driven by evidence together will take us there. Thank you so much. I appreciate the opportunity to share with you my perspectives on where we should be headed in terms of moving the health system to the next level. Thank you.
Thank you, Professor. You may not hear the clap, but it's very loud. We have one more presenter. Unfortunately, we've really run out of time, and I hope she will be. Dr. Biachika, are you online?
Yes, Chair, I'm ready.
Okay, so Dr. Sarah Biachika is the current Commissioner Health Services, Policy and Planning in the Ministry of Health. She's a medical doctor and a public health specialist with a long experience serving in the Ugandan health sector at different levels, from being a DHO in Jinja District and also a former Assistant Commissioner, QAD, Ministry of Health. She's now a member of the Strategic Committee for the COVID response. You're welcome, Dr. Sarah Biachika, to give us a presentation. We only have 10 minutes. If we at all we don't have time to debate.
Thank you, Chair, and good afternoon to all you delegates to this conference. I'll give you just a quick overview of the difference that RBF has made in improving service delivery. So my presentation first is to give us an outline of how far RBF has gone. And in terms of coverage, we have covered all the districts in this country, all the local governments, but this has been in a phased manner, starting from January 2019 up to 2020. So you can see the different shades show the rollout of this program, largely implemented by the AMCHIP project, as well as Enhancing Health in Acholi, a sub-region funded through USAID, implemented by Enable. AMCHIP is implemented by the Ministry of Health. So in terms of coverage, in respect to AMCHIP, we have a total of 1,423 health facilities implementing RBF, of which 79 are health center 3s, 13% health center 4s, and 8% hospitals. The public facilities constitute the biggest share of 81% of all the facilities implementing RBF. In terms of disbursements, since we started, because we always start up with startup funds for all health facilities, but in terms of quarterly disbursements, now we have 2.5 years of disbursing funds, and these disbursements have increased from 870,000 million in the first quarter to now currently $6 million US dollars disbursed on average per quarter to the facilities that I've mentioned. In total, we have disbursed up to 33.6 million US dollars for RBF implementation in all the implementing local governments under AMCHIP. So there are two major core objectives of this program. One is to increase utilization of key services, but with focus on primary health care. And secondly, to improve the quality of services, however, with focus on improving efficiency and equity. So in the area of outputs or utilization, this slide shows us a comparison in change in performance in terms of outputs for the 12 incentivized indicators at health centers 3s and 4s. The first one you can see OPD attendance under 5. Between financial year 2019-20 and compared to 2018-19 and 2019-20, we saw that in the last year, there was a drop in OPD attendances. This results in reduction in incentives because we incentivize outputs, but in the public health perspective, this could be an indicator of either showing improvement in the prevention services with less under 5 children falling sick, as we saw in the reduction of some of the diseases, but also it could be attributed to the lockdown effects, whereby there was a reduction in attendance for in some of the districts as a result of lockdown. However, for most of the RMNCH indicators, we have seen a percentage increase or improvement in terms of the outputs despite the lockdown effects. As you can see, I've highlighted around here the referrals in. We have seen a drop in the referrals to facilities, but this could be attributed to improvement in service delivery in those facilities that we are referring, especially from health center 3s to 4s. As the center 3s become more functional, there are less referrals. So that is also a good aspect to show improvements in quality of care. In utilization of services. In terms of quality of care, this slide shows us is disaggregated per phase of implementation. On my far left, I can see that phase 1 districts, there has been improvement both at health center 2s and 3s in terms of quality, with the health center 3s having 89% score in quality on average and 4s 91% in the last quarter. Phase 2 districts, we are seeing that there's not much change in terms of quality. They are stagnating at around 87, 86, 85, 87, within that range throughout the quarters. However, for phase 3 facilities, we have also seen positive trends. Now, the difference between, for example, phase 1, 2, and 3 districts in terms of RBF is that phase 1 districts were those districts that were selected under phase 1 because they were performing very poorly in terms of RMNCH indicators. And so it is good to see that these districts have actually improved in the area of quality and are sustaining that. The phase 2 especially were averagely performing, and they could still be in that laissez-faire mood and need further support to improve. So in terms of quality, we assess up to 9 domains, but generally the trends show improvement in leadership, human resource, and financing. Although for health information, medicines, and equipment, we seem to be stagnating or plateauing off in terms of quality parameters, and then infrastructure, client-centeredness, and client management show significant improvement as well. We also look at performance of the EDHMTs, the Extended District Health Management Teams, and improvement has been realized in the area of supervision, but area of DHMT meetings is struggling, could be attributed to the workload experienced during COVID, but we don't know. But however, performance reviews have improved. Timeliness of submission of HMIS reports have improved. Financial management, functionality of QI system, maternal perinatal death reviews are not yet performing satisfactorily, including health, medicines management. So, Chair, in terms of time, I'm rushing through, but some of the quick observations are that RBF has contributed to medicines availability. We are seeing between 1 to 1.5 billion shillings being used to procure additional medicines on a quarterly basis. There have been significant infrastructure investments and staff motivation as a result of the flexibility where they have funds to implement work plans to address bottlenecks, but also the 40% staff incentive has also had positive effects, especially on reducing absenteeism and focusing on outputs. We've realized improvements in reporting and data quality in terms of accuracy, but as well as timeliness. So this shows, for example, some real tangible investments that have been made towards improving service delivery. Procurement of equipment, for example, a March Health Center 4, they have been able to procure HemaQ machines to be able to take HB machines, HB for all their pregnant women, TV screens for antenatal, improved on the beds in terms of Macintoshes, fridge for the lab, and a number of investments have been done to improve on the work environment, but also to improve on the quality of services. This is a My Hospital PNFP. They have been able to procure an operating theater table, anesthetic machines, oxygen concentrators, put up an incinerator, and other improvements in infrastructure. So in conclusion, RBF has contributed to improving and strengthening the health system. It is one of those interventions that has contributed to sustained health service delivery during the COVID-19 pandemic. As you can see our indicators, we had our annual review last week, but compared to other countries, we have not really seen much decline in terms of the achievements that we had made before. It provides an opportunity to objectively allocate resources based on agreed outputs, and now government is planning to mainstream RBF in the PHC funding beginning financial year 2022-23. The autonomy and flexibility allows resources to be invested in systems-wide priorities, as I have said, and non-cash incentives are a key motivation. However, RBF is not a magic bullet. It requires a supportive environment and other support functions to work well. Not all facilities are performing well. We have those that require to strengthen governance, improve accountability and transparency, and largely digitization of the medical records to ensure timely reporting and performance monitoring. Chair, that's the quick overview, and thank you all for listening.
Okay, thank you, Dr. Sarah Biachika. We've had 4 wonderful presentations. 2 people are seated right in the front here, and 2 people are online. Given the fact that the end time has to be kept, you can check in the program. We have just used up all our time. So and the 4 presentations are kind of tied in. So can we allow 2 questions from the room? Those we must have, and then we shall allow the next chair to come and usher in the new team. One lady here and one gentleman there. Sorry, I don't know everybody's name. In fact, I also didn't introduce myself. My name is Daniel Chavainze. I work in the Ministry of Health. So please go ahead. Could we have the microphone right to this lady in blue and the gentleman towards the other camera? I'll come around for another set of questions after those two. If you make them shorter, then others will have a chance to ask. Have a challenge passing the microphone around? Okay.
It's not a question, but to highlight and us on one of the solutions we are using, basing on Doctor's presentation about NCD's management, and it became handy during the lockdown on using telemedicine during that time, as practical is happening with Rocket Health. We use telemedicine as one of the tools to reach out to. Like, I've seen it helping management of NCDs, because majority of our clients, you're able to get your timely refills, you're able to get a specialist doctor at your comfort of your zone. We
Recording
reach out to
stop. Recording in progress.
We reach out to you wherever you are, and at least I know there are some people who can attest to that, using telemedicine, because it's not crowded. I come to you with your medicines on time. You don't forget, you get your full refills on time. Yeah, thank you.
Thank you very much, Chair and the presenters. Chakwa Richard Juko is my name. I work for local service partner TASO. My first question goes to Dr. Nachireka. You clearly mentioned that one of the drivers for these NCDs is rapid urbanization. And we are very sure that the people to address this are the policymakers, who are often at time not in some of these conference meetings. So my question to you is, at what level are we engaging, and how are we engaging these policymakers to ensure that they take up some of these critical processes that are responsible for averting non-communicable diseases? My second question goes to Professor Roda. It is very evident that even at this conference, many of the presentations were clear that implementing partners are supporting these processes of ensuring that they enhance services. However, we also know that there has been a number of declarations worldwide, and I will quote one, the Abuja Declaration of funding the healthcare sector to about 15% of the government sitting. So you observe that in many of the African countries, this is not happening. So my question to you is that, apart from these implementing partners, how do we make sitting governments accountable to create resilient and self-sustaining systems to ensure that they improve their healthcare processes? And finally, to Dr. Byachika, we have observed in one of the slides that you have presented an astronomical drop. I think it was among the phase 3 facilities out of the health center falls. What could be the explanation to this astronomical drop? Afoyo Matek.
We allow one more person behind there, the lady there, and then we allow the discussants to give the questions. There is a lady right behind this one here.
Thank you so much. My name is Kovia Kembawazi. I work as a nutritionist for the local government. Mine is actually more of a concern that goes to the first presenter. I think that's Dr. Susan. Most times we've seen NCD patients or clients at the hospitals, their services are more inclined to doctors, to treatment. So whenever they come to the hospitals or wherever they get their treatment from, they tend to move to doctor's room, but then we're aware that their treatment or the management of NCDs is sort of, it's a cocktail of efforts. So how do we ensure that we harmonize these services that we give to these clients, not just them coming and see the doctors, then they go back home, because they tend to focus more on treatment than prevention. Thank you, I submit.
So we shall have responses to those 3 questions, and then should time allow, you will be next, sir. Okay? Can we have Dr. Susan, then Dithan, then Professor Rhoda.
Thank you very much for those contributions. The lady who talked about the role of telemedicine in improving NCD care, it's actually one of my recommendations, to have telemedicine services, especially in this season of COVID-19, where lockdowns cut off patients' access to their health facilities, to their health care providers. And this would be possible if there were electronic medical records where you can track patients and be able to follow them up according to their appointments. So it's something we need to start thinking about. And someone talked about engaging policymakers. I mentioned that the NCD Department, Ministry of Health, is present here. And we have actually engaged policymakers. We have had several meetings with the Parliamentary Forum on NCDs. We've also yesterday just had a meeting with the mayors of the cities in Uganda. So we think that this is a talk we should keep furthering so that we are able to realize our policymakers coming on board. Of course, they should be leading this, but it is something that we have taken on seriously, and I'm sure if we asked our commissioner to say something, he would add a voice to what I'm saying. And finally, doctors being the sole providers for NCD care, it's actually a true reality that most NCDs are managed by doctors, which shouldn't be the case. And we are thinking that just like is the case for HIV, where treatment was scaled down to lower health care cadres, we should now start thinking of scaling down healthcare to lower cadres, to engage the VHTs and other cadres because of these growing numbers of patients. So this involves training of the different cadres in NCD care, which is something that has not taken root as much as has happened in infectious diseases. Thank you.
Chair has picked on me, but I didn't get a question. Maybe I can formulate one very quickly. Yes. I know the questions were dedicated, raised for Dr. Biachika. In terms of hand hygiene, environmental hygiene, we better get used to using some of these sterilizers, making sure that we wash our hands as frequently as possible. Some of these viruses, the bacteria, the pathogens, can actually stay on these surfaces for close to 72 hours. So just in the course of the last 3 days that we've spent here, there's a chance that some of you could have picked up some of these pathogens, and then you end up taking them to your residences. That's something to be mindful of. But Richard, in terms of the policymakers, I guess we need to define who a policymaker is. When you look at just this conference per se, we have pretty much the leadership of the entire Ministry of Health, and these are the key decision makers, the policy makers, who are supposed to really translate a lot of these discussions, recommendations into policy and action. Thank you, Chair.
Professor Roda, and then Dr. Sarah Byachika.
Thank you, Chair. I'll start with a comment in the chat, I think from Dr. Stavia Triahawe, who says we should move towards a people-centered public health and prevention. Yes, we should. That's exactly what I was speaking about, and thank you for packaging it well, because in terms of efficiency, in terms of making sure that we can address in a very comprehensive way a lot of issues from promotion right to rehabilitative services. We can't afford to just continue with only disease-specific interventions. Although sometimes you might prioritize a certain package of diseases for more action if they are causing the biggest harm to the communities, we need to address issues in a more comprehensive manner. And we need to approach the health system in a similar way. The question around, yes, the IPs are supporting the health systems, and we have not yet reached the 15% contribution from government based on the Abuja Declaration. Yes, that is a major concern for us. We need to be moving towards that. And I think now is the time for us to accelerate the efforts to advocate for and track and ensure that we move to that level. We have just gone through and we are continuing to struggle with COVID. And right now, all governments realize that health is indeed a security issue, health is a development issue, and that it's not a luxury for us to invest in health. So we need to build on this momentum. Many countries in Africa are beginning to rethink their investments in health and making sure that they are more sustainable in their investments in health and various components of their health system. So I hope that we are not going to be left behind in this, and we need to all ensure that this does not happen. And this is an area where we will need multiple actors. Yes, we are not going to just look at the Ministry of Health, there's government, and there's all of us up to the community level. We all need to play our part in the issue of accountability. Accountability is a cross-cutting framework, and it doesn't lie only in one space. So I wish we had enough time to actually tackle this more comprehensively, because me who is speaking, the colleague who asked the question, sorry, I didn't get the name, and everyone here listening, we all do have a role, and we need to play our role to make sure that health remains a priority, and not only in speak, but is reflected in resource allocation, and that the missing pieces in terms of the policy frameworks that needs to move us there are also addressed. Thank you.
Dr. Sarah?
Yes, Chair, I think I had only one issue to explain the drop in performance of some of the indicators, especially for phase 2. Yeah, we realized the drop in quality performance assessments indicate scores, especially in Q2 of financial year 2021. And as you all recall, that is the time we had the lockdown for COVID. So there were a number of gaps also. COVID affected service delivery in terms of a number of facilities were not able to conduct their routine meetings, management committee meetings, CHUI meetings, There were incomplete registers in some facilities because of a few staff, some staff were not attending. So COVID to some extent also affected the quality of services, and that's why you see that there was a drop across the board in Q2 of financial year 2020-21. Thank you.
Thank you, Dr. Sarah. We shall have one more round of questions. I had already pre-selected one person, so I'm going to learn how to look in the periphery. Can we show of hands who is interested so that I can also be selective? Number 1, number 2, and number 3, then number 4, if time allows. Okay? So better if you keep it to one question. Mr. Juko asked for, so the next people given the opportunity, keep it to one. Can we have a microphone, please?
Yeah, thank you very much, presenters. I'm Dr. Namagala Elizabeth, Minister of Health. My question, I think, goes to the whole panel. I just wanted to say that I think as a country we need to learn and we need to style up as a country. Just to give an example, in Kenya, when they were rolling out treatment for HIV, they set up new centers and they just extended part of their facilities and called them comprehensive care management centers just to manage HIV, because they knew in future they would build onto them management of other diseases, chronic diseases. So my question is, as a country, how are we leveraging the learning, the resources, the goodwill that has gone into managing HIV? I mean, we have treatment of HIV up to the health center 2 level, and we have drugs for them, we plan for them, we have actually whole programs just looking at HIV. How can we leverage whatever we've done for HIV to help us scale up management of all other chronic diseases? Because I've seen so many patients who have diabetes who can't afford insulin, and they're just left out there in the cold. And the drugs are much cheaper than ARVs. I just wanted to know how we can actually style up as a country, as the brains for for health in Uganda. How can we ensure that we leverage what we've done for HIV to manage chronic diseases in Uganda?
Thank you, Dr.
Thank you.
Elizabeth. I already selected some people. I had said number 1, number 2.
Chair, it's only the order, otherwise I was also selected. But it's,
okay.
It's just a matter of the order.
There is always what they call a birth order. If you upset it, you'll be in trouble.
Thank you very much, Chair. I'm Dr. Gerard Mutunji, Assistant Commissioner for Non-Communicable Diseases. I wanted to appreciate the one who said that we are not talking to policy makers in these workshops, but I wanted to reassure him that we realized that and we are talking to policy makers. We have met parliamentarians, and after meeting them and sensitizing them about non-communicable diseases, they actually went to Parliament and discussed that and passed actually a motion that NCD drugs should be available free of charge to those who are suffering from non-communicable diseases. Whether that will be followed with resources is a different question, but at least that one was done. Yesterday we met mayors, city mayors, and town clerks of all the new created cities, including the old one, the capital city. And again, we sensitized them, and we even wrote, they signed a commitment that they are going to prioritize non-communicable diseases. And we are forming a multi-sector committee because we know that risk factors for NCDs are not a mandate of the health sector. There is the Ministry of Works, there is finance, there is trade, so we are forming a multi-sector committee to discuss and agree on strategies for non-communicable diseases prevention and care. And I wanted to tell my neighbor that there is a study ongoing on how we can integrate management of non-communicable diseases into HIV care, so that instead of calling them at clinics or what, can we call them chronic care clinics? Because the way we manage hypertension, the way we manage diabetes is the same way we manage HIV. The difference is the drugs that they take home. So there is a study ongoing, and I hope it will inform policy that instead of having these silos, we have chronic care clinics where every patient with a chronic condition can go and receive care. I thank you.
Dr. Gerard, those were very important observations. I'm glad you insisted.
You Chair.
But he's also mentioned we do
Can
our
also volunteer to take the microphone.
Okay, thank you. So that you keep active. So sorry for those who put up their hands first. We've done reverse order.
Thank you. Thank you, really, the panelists, for an excellent session. My question is for Dr. Susan Nachireka Tumwesiji. I'd like to know about your perspective on managing comorbidities, because I work with the HIV and TB programs heavily, and they've already realized that hypertension, diabetes, and also a bit of mental health, when they are combined with HIV and TB, the mortality is very, very high. And the studies are clear that these patients need special attention, and so they've moved towards addressing this within the HIV and TB settings, trying to have all treatments available at these points. So now, since you're from the other side of the NCDs, what's your perspective, what's your expectation, what's your observation, your wish, what should be done at national level, subnational level, at the front line, in the communities, through the NCD program that is there today, to make sure that the people who have all these comorbidities are managed properly? Thank you.
So can we have our last question? The gentleman here in the blue mask.
Thank you, Chair. I would like to contribute. My name is Alphonse from IDI. I would like to contribute to a presentation made by Dr. Dithan Chiraga. First of all, I want to thank you for the innovations and contributions towards improving IPC. I've done some work on IPC for over a year now. However, IPC is, it has been there, but it has been awakened due to the COVID-19 that we got. And some work is going on, but the challenge, the biggest challenge is sustainability. Certainly, being a new concept, people tend to drop off, having their focus on it. So I think, in my opinion, and what I've seen in some work that we've done in Bunyoro and West Nile, I have come to realize that we need to have it fully integrated. Have a structure at the DHO's office with a focal person, which focal person is responsible for ensuring that facilities adhere to the IPC protocols, gives reports during review meetings at DHO's level, DHT meetings, issues are discussed, and actions are taken. Also integrate the same in the routine support supervisions done by the DHO's office, and make sure that the tools are part of whatever supervision is happening in the facilities. That is one thing that will keep the IPC protocols being followed by health workers, and then eventually we'll have our health facilities very safe.
Thank you very
That's what
much.
I wanted to share.
Thank you very much. I'll allow the panelists to contribute their answers to whichever questions they picked up. And it seems our time is well spent, but also Dr. Nachireka, when you mentioned everything was about men, 40% alcohol, then they are at risk of second-hand smoke, you have to elaborate, what are men more at danger?
Okay, thank you. Before I go to that, Dr. Esther, I want to inform you that what you mentioned was partly answered by the Commissioner. We need to see that just like has happened with HIV, where they have a clinic which is manned by trained health workers, a clinic that has people going out into the community and educate people and screen, and follow up patients. We saw during COVID-19 that HIV patients continued to receive care. They used all means to reach the patients at home. These are patients who have treatment supporters. So that is the kind of thing we are looking at for NCD patients. Unfortunately, on the NCD side, you find that someone has diabetes, hypertension. The clinic days are on different. If a clinic day for diabetes is Monday, hypertension is Wednesday. And if you find that you have HIV, then that will be Thursday. And if on top of that, if you have asthma or COPD, that will be. So you find that you spend your week running from clinic to clinic, and you're not able to be followed up appropriately. So that is the kind of thing we want to see in NCD care. But also, we saw a lot of training in HIV care. I was one of the beneficiaries of these trainings, which went down to the lower cadres. So we want to see more people trained in NCD care so that we can handle these big numbers of patients that we are seeing. So of course, Dr. Dan is asking if men are more at risk. If we look at statistics, I think the different diseases affect the sexes differently. However, we need to remind us that we are all at risk. First of all, obesity is highest in women than men. African women are more likely to be obese. And it used to be some kind of culture to have a round lady. But we are now also seeing obesity growing in the men because men have stopped being hunters, going out to the field to hunt, but doing most of desk kind of work. And of course they have opportunity to eat out because they are the ones who earn the money in most cases, so they move out and eat and indulge and all that. So the risk cuts across, and all of us are not safe. I'm sure each one of us has had someone who has suffered from an NCD. Someone has lost a loved one due to an NCD. We are all at risk, including our children, and we need to do something. Thank you.
Ladies and gentlemen, can we clap for our presenters? And in fact, you should also clap for yourselves for staying all the way to the last session. So we are moving into the final session. I call up the Master of Ceremony as we resume our seats.
Thank you very much, our chair, for this session. And allow me appreciate all the presenters. From us, the Masters of Ceremonies, we are headed into the closing ceremony for an engaging 3-day annual National Healthcare Quality Improvement Conference. And we were privileged to have a number of presentations, keynote addresses, and our closing ceremony will be as follows. We are going to have a statement by Dr. Emilio, who is the branch head of services at Centers for Disease Control. Then we shall go into the award ceremony for the key performers and also those that have supported this conference. We shall also have a speech from the Honorable Minister of Health, and we will have a closing prayer and also departure. The closing prayer will be given by Dr. Agure Batesaki. Ladies and gentlemen, I think we need some sort of break and exercise. I would request everyone to stand as a way of preparing for the closing ceremony. Let's at least, since the discussions have been dominated by NCDs, let's at least have a moment of stretching. Okay, I think that is enough. I'm going to take this opportunity to welcome Dr. Daniel Chabainze, the Director of Public Health at the Ministry of Health, to lead us through the closing ceremony. And I will also request my co-MC, Sereko, to take charge. I will be leaving shortly. I have another ceremony also to attend at the residence of the French ambassador. So thank you on behalf of myself. I wish you good deliberations as we go through the closing ceremony. Dr. Daniel, you're welcome.
Ladies and gentlemen, I have a second chance to sit here to chair the closing session. I am double lucky. My task is very simple, is to invite Dr. Emilio to come and speak to us on behalf of the US government as part of the closing remarks. And you're welcome, sir.
Thank you so much, Dr. Daniel. Good afternoon. Minister of Health, Honorable Dr. Jane Ruth Achang, UNICEF Country Representative, Dean of Makerere University School of Public Health, Professor Rhoda, Commissioner of Health Services Planning, Dr. Sarah, Chair of RRH Directors, Dr. Nathan, and all our discussants for today, members of the Health Services Commissions present and senior technical advisors of the Ministry of Health, health managers from regional and district health institutions who are present, members of the Academy and UN agency representatives, my USG colleagues who are present, and all colleagues, please help me observe all protocols. To everyone that's here today, I bid you a good afternoon. I'm pleased to be speaking to you on behalf of the U.S. mission in Kampala as we officially close this exciting 3-day National Quality Improvement Conference, the 8th conference of its kind. I'm excited to be with you in person, and I bid a word of welcome to all participants that are joining us virtually, which I think really demonstrates the stronger command of virtual platforms and social media, which we've adopted this year just as we did last year. I think we can all also agree that while COVID-19 has had devastating impacts, it has also been an opportunity to innovate and to adapt so that we can emerge from this pandemic stronger than we were when it started. Not only is this in keeping with the spirit of continuous quality improvement galvanized by this conference, but also we're ensuring that we're always innovating, adapting to continue to deliver high quality health services during the pandemic and beyond, as demonstrated by so many of the presentations that have occurred in the last 3 days. The US government has enjoyed an enduring partnership with the government of Uganda and local stakeholders, and we've leveraged the strengths of multiple different US agencies towards that end, like the Department of State, the Department of Defense, the US Agency for International Development, USAID, Peace Corps, the National Institutes of Health, or NIH, and my own agency, the U.S. Centers for Disease Control, where I serve as the Health Services Branch Chief. Our programs are helping the Ministry of Health fight COVID-19 and other infectious disease outbreaks. We're improving maternal-child health, reducing TB and malaria deaths, supporting Ugandans living with HIV to live productive, healthy lives, and training local health professionals to better care for their fellow Ugandans. I'm glad that all these programs have been covered in the last 3 days of presentations. I'm also very happy to see the diversity and geographical coverage of the presentations over the last 3 days. In terms of age, we've talked about children, adolescents, and adults. In terms of reach, we've gone from the central and southwestern districts of Kampala, Masaka, and Teso Soroti, places where I've had the privilege to visit over the short time I've been in Uganda. We've also gone to Lengo, Ancholi, Karamoja regions in northern Uganda. We are all particularly excited to see data-driven decision-making for innovation and addressing existing gaps within the healthcare system. That is why it's been exciting for me to see the range of discussions and topics that have been shared during this conference, such as continually improving access to coverage, access to and coverage to HIV and TB services, expanding screening of cervical cancer for women living with HIV, improving maternal and child care, and activities that have increased our patient and health worker safety with the implementation of infection prevention and control strategies, as well as expanded COVID-19 vaccination. Those activities that are importantly addressing vaccine hesitancy, as well as mental health needs and gender-based violence. I'm especially delighted to be supporting the Ministry of Health through the PEPFAR organization, especially as we develop the database that will track implementation of all continuous quality improvement work that will be conducted in the country. The launch of this database and its subsequent utilization will empower the ministry to provide and monitor CQI activities in all districts in all regions. This year's conference theme, Fostering Delivery of Quality Healthcare in the Context of COVID-19, could not be more timely, as it showcases experiences, challenges, and importantly, opportunities for implementing quality improvements approaches in healthcare throughout the COVID-19 pandemic. Now, despite prolonged uncertainty and ongoing waves of COVID-19, I am proud that the US government has contributed to ensuring the continuity of quality health services during the pandemic. Uganda, like many other African countries who are benefiting from PEPFAR support, has experienced significant challenges and disruptions to its HIV and TB programs during the last 2 years. Ugandans have lived through 2 COVID-19 lockdowns, which saw many of our healthcare facilities reach saturation and capacity, increased deaths due to COVID-19, long-term school closures, and slow vaccine rollout that was in part due to difficulties in getting the vaccine into the country. With the goal of protecting our hard-fought gains over the last almost 40 years of combating the HIV epidemic, I'm excited that we've been supporting Ugandans to come out of COVID-19 stronger. PEPFAR leadership was quick to provide technical guidance in the context of COVID-19 to not only ensure uninterrupted care and treatment for those Ugandans living with HIV, but ensure that that care was being provided in a safe manner by supporting infection prevention and control activities down to the health facility level. Indeed, when we look at the data, we're actually exiting the second wave of COVID-19 stronger than we were before we started the COVID pandemic. And here are some details for you. At the beginning of March 2020, at the end of March 2020, right before COVID hit, to September 2021, just 2-3 months back, the number of Ugandans living with HIV who are now on treatment has increased from just over 1.2 million people to well over 1.26 million people. That's more than 60,000 people who are receiving life-saving drugs for HIV. And we know that once you're on drugs for about 3 to 6 months and your viral load is suppressed to a level that's undetectable, you can no longer transmit the virus. So we're saving the patients and stopping new infections from happening. We've also expanded client-centered care by offering more and more clients the ability to have multi-month dispensing, so they don't have to come into the clinics as often. That proportion has increased from 48% to 74% by the end of September. And finally, we've optimized HIV treatment through the scale-up of dolutegravir-based treatment regimens, which has been evidenced in our viral load suppression rates, which I can say have now increased to their highest levels ever, reaching the important UNAIDS targets of 95, 95, 95. This is an incredible moment in the fight against HIV. I agree. Thank you for your partnership and dedication towards fighting this epidemic during the COVID-19 pandemic. Currently, PEPFAR has prioritized continuity of treatment by building on what we have learned so far to be effective in keeping Ugandans living with HIV on treatment and healthy despite such interruptions. The experiences shared by different presenters throughout this conference demonstrates the adaptability of the healthcare system to service those needs. The US government has also provided technical assistance in infection prevention and control to minimize the risk of transmission, especially at the site level. As the country has entered a 42-day lockdown to contain rising COVID-19 infections, the US government quickly mobilized our partners to embrace flexible interventions such as multi-month dispensing, as well as the use of virtual platforms to minimize the risk of infection at the site level, but also by being able to be at the site level with those frontline workers who needed that support. Looking at what the US government and partners have achieved in this period, despite the challenges, is awe-inspiring. And the presentations that were given in the last 3 days are just the tip of the iceberg of the many efforts that have happened over the last 2 years. Proof that we're moving forward in our efforts to reach HIV epidemic control, end tuberculosis in Uganda, as well as other important targets for our healthcare system, despite the COVID-19 pandemic. In closing, please join me to appreciate the Ministry of Health for their leadership in ensuring continued delivery of health services amidst this COVID-19 pandemic. I also want to acknowledge the contributions of our US government partners in preparing for the conference through the development of abstracts and presentations that have provided us with a wealth of knowledge on how to improve and adapt quality healthcare services despite the pandemic. A big word of thanks to the conference organizers. We commend you for your adaptability and your work well done. Great presentations in the most flexible and safe of manners. This is fantastic. And with 18 years of PEPFAR experience so far, and as we approach 60 years of collaborative partnership with the government of Uganda, the United States remains committed to helping Ugandans live healthier and safer lives. With that, I wish you all a great weekend, and thank you.
Thank you, Dr. Emilio, for representing the US government, our greatest partner in health, especially in HIV/AIDS care. I can't reiterate what he said, but can we give him another round of applause? So he's also represented the rest of the partners who would have given closing remarks. And I think we quickly now move to the next stage. I want to take this opportunity to welcome Dr. Joseph Okware, who is sitting here on behalf of the Minister of Health, Dr. Jane Ruth Acheng. Honorable Minister, as you are aware, Ministry of Health and her partners have over time recognized outstanding performers in the sector in different ways. This time, in the same way, we are closing the 8th QI meeting national conference. We want to recognize more people. Thank you for the interlude. As we've done in the other national conferences, we've recognized people who have, for a long time, supported with commitment to the growth of the quality improvement in the country. This is, however, not to say that there are no more others who have done tremendous contributions. Subsequently, more persons and institutions shall be recognized and awarded in a similar way in the progressive and future QI conferences. Ladies and gentlemen, allow me to read for you the criteria we've used to select the people who are our recipients this afternoon. These people have provided technical support to the QI implementation in the country for more than 10 years. The technical areas in which they have supported are the following: development of the QI guidelines, policies, standards, and SOPs. QI support supervision, coaching, and mentorship. QI monitoring, learning sessions, review and evaluations, and building capacity, both in terms of teaching and training. Number 2, these people have supported QI at national level and sub-national level, including district level and sub-district level. Number 3, they have spearheaded QI research, operational research, leading to the development of different care packages. These have been also known to have contributed to publications and dissemination of QI innovations. Number 5, they have advocated for funding for QI initiatives. And it's good that most of our partners who have been funding are here. They will attest to the people we've selected. Finally, these people have created visibility for quality improvement in the country through the presentation of high-level meetings, conferences. Honorable Minister, sitting in for Dr. Ruth, I now want to take this honor to present to you the following people who are going to be read by Dr. Batesachi. And once these people are read, we will allow them to come in the front and take a picture. And they'll stand in the front here, take a picture with us to symbolize that they are receiving the award, which placards are going to be handed over at a slightly later time. So, Doctor, you are welcome. So we all move to the front. So, Dr. Emilio, we move to the front to receive these people.
Thank you so much, Chair of the session. Honorable Minister, before I read the recipients of today's awards, I want to, first of all, register our sincere apologies to the recipients this evening that we have been somehow let down by the supplier, one of the best, by the way, in the country in that regard. He has been unable to deliver the plaques for the recipients or for this function. And for that matter, therefore, Honorable Minister and Chair of the session, we are going to read the awardees or the recipients. They come in front here, and since we are in the COVID era, they can't shake hands with you, Honorable Minister. They will just stand in front of the high table and take a picture for their files. And as I read the names, our IT team will be displaying the plaques on the screens for all of us to behold and to authenticate that the awards or the plaques are being worked on. And they will line up in front here and then take a picture, a photo with you, Honorable Minister. I therefore now take this singular honor to present to you, Honorable Minister, the awardees in regard to what has been presented by the chair of this session. Number one is Dr. Alex Kakara Mushiso. Dr. Alex Kakara Mushiso works with the Ministry of Health. Number two is Mr. Julius Sendiwala. Mr. Julius Sendiwala works with the Makerere School of Public Health, METS. Number three is Miss Evelyn Akero from Makerere University, METS. Evelyn Akero. I want to encourage you to clap more strongly because you never know, it might be added to the criteria of selection next year. So, number four is Dr. Bruce Agins from working with UCSF, Dr. Bruce. Number five, Honorable Minister, is Dr. Elizabeth Namagala, Minister of Health. And Honorable Minister, you can see from the screen in front of you that the plaques are being displayed, and the audience can view from the screen is in front. Number six is Dr. Tumwesije Tuhwezeine Benson, Minister of Health. That is Dr. Benson Tumwesije walking in front. And the lady behind him is Dr. Elizabeth Namagara, working with the Ministry of Health, SCAP Department. Number seven is Dr. Muhwezi K. Augustine of USAID. Honorable Minister, Dr. Muhwezi Augustine is the Chief of Party Rights EC. Number eight is Miss Juliana Nabwire of Rights North Acholi. She's right there walking in front. Miss Juliana Nabwire, Rights North Acholi. Congratulations, Miss Juliana. Number nine, Honorable Minister, is Dr. Esther Karamaji Nkolo of USAID, working with USAID. Honorable Minister, that is Dr. Esther Karamaji Nkolo. Number 10, Honorable Minister and the members present, is Dr. Ibrahim Chirunda of WHO. Honorable Minister, I want to attest that Dr. Chirunda Ibrahim, Dr. Kakala Mushiso, and Dr. Tumwesije Benson taught me QI about 15 years ago when I was a young medical officer. Number 11 is Dr. Herbert Kadama. Dr. Herbert Kadama. Honorable Minister, I'm sure you've heard someone saying, yeah, continuing to confirm that the criteria was used very, very well and the rightful people were selected. That's walking in front is Dr. Herbert Kadama. Number 12 is Dr. Geoffrey Kaita of Affinet. Dr. Geoffrey Kaita of Affinet is there walking in front. And his plaque has been flashed. Is Dr. Godfrey Kaita. Number 13 is Dr. Haddison Ibalidawa. Dr. Haddison Ibalidawa. Yeah, someone was almost urinating for Dr. Haddison Ibalidawa. Yes, I was also privileged to sit in many of his classes of QI many years ago. Number 14 is my senior in the department, Dr. Martin Sendiona, Minister of Health. Honorable Minister, I'm sure you know, but I can remind the audience that the gentleman walking in front is Dr. Martin Sendiona, the head of department SCAP, the department responsible for quality improvement in the health sector. I want to request us that we give him a more louder hand clap. Honorable Minister, I also want to add that Dr. Martin Sendiona works quality improvement. Number 15, Honorable Minister, is one of your directors in the Ministry of Health, and this is none other than Dr. Joseph Okware. Number 15, number 16, and number 17, Honorable Minister, were awarded in 2019. We are given the same award in 2019, and these are Dr. Sarah Biachika and Dr. Henry Mwebesa. Dr. Sarah Biachika is Commissioner Planning, Finance and Policy in the Ministry of Health, and Dr. Henry G. Mwebesa is our Director General of Health Services in the Ministry of Health. And all of us can attest that these are gurus in quality improvement in this country. And now I can see the cameraman getting ready to capture this very important occasion. And I can see Director Public Health, Dr. Dan Chabai, is trying to guide the recipients on how they can get a very, very good photo for their libraries. And now, Minister, it's upon you to decide where you will stand, given the advantages that you have over all the awardees. I can see the cameraman trying to guide. This is a very, very important moment, which I can see the cameramen don't want to spoil at all. Thank you so much, cameramen and women. Yes, it is okay, and it will be very memorable that they got awards during the mask era. Yes. You never know, they might be the first and the last to receive awards with masks in our 2I conferences. Thank you so much. We can give them a thunderous clap as they go back to their seats. Congratulations, the awardees. I want now to hand over to the Master of Ceremonies to continue from here. Master of Ceremonies.
In the absence of the Master of Ceremonies, I will take this singular pleasure to invite the Honorable Minister here represented by Dr. Joseph Okware to give his closing remarks and close the conference. You're welcome, sir.
Thank you very much. This is the problem with height. Good afternoon, ladies and gentlemen. We have come to the end of our three-day conference. And as we had expected, the Honorable Minister for Health, Dr. Jane Ruth Acheng Ochero, was with us at the beginning of the conference and officially opened the conference and blessed this conference and promised to be with us today for the closure. And indeed, yesterday, I was with her in Gulu for another function, but we made sure we came back in the night for this closure today. But unfortunately, just a few minutes ago, some other issues came up, and she found that she was not able to be here in person. But she's online, and she gave me a very difficult task. Her instruction, if I can share with you, is that, Joseph, you close the conference, but speak in my voice. So I don't know whether my voice is anywhere near near the voice of Honorable Minister Acheng. But whatever bass you are hearing, please know that this is Honorable Acheng speaking. I'm not representing her, but I'm reading her statement for closure and her speech, although in a different voice. The branch chief of Health Services, CDC, Dr. Emilio, who has spoken on behalf of USG, the Director of Public Health, who has chaired the sessions today, all senior staff of Ministry of Health, heads of department present, distinguished members of the academia present here, the district health officers and your staff who have managed to come and participate in this very important annual conference, officials from other ministries, departments, and agencies who have joined us this year, health implementing partners, our very good partners who are still with us online and physically here, representatives of civil society organizations, staff of Ministry of Health, all our health workers physically here, and those back at home and have participated in this very important meeting. All invited guests physically present and those online. Ladies and gentlemen, good afternoon to you all. That good afternoon is from the Honorable Minister, and she greets you all. It's not from me. The Honorable Minister, Jane Ruth Acheng, would like to congratulate all of you, the participants of the 8th National Quality Improvement Conference for the health sector, upon successfully completing this 3 days conference at Munyonyo Commonwealth Resort Hotel. She extends her appreciation to the presenters of the oral and poster presentations at this conference. She says that she thanks you so much for taking time to prepare, to implement, to document, and to share the work you have been involved in for the last 1 year in delivering health services. She's particularly impressed by the quality of documentation and presentation shared in this conference. And she says, thank you very much. You can clap. Allow the Honorable Minister also to appreciate our keynote speakers that we have had in the 3 days, day 1, day 2, and day 3. On day 1, we had Dr. Carlos Javia, the Executive Vice President for the Technical Programs from University Research Council, URC, USA. We also had Professor Handa Yujiro from JICA, Japan. And today we had Dr. Olive Sentumbwe Mugisa from WHO here. And we also had Dr. Richard Idro, a senior lecturer at Makerere University. These 4 were our keynote speakers this time in this conference. And the minister would like to thank all of them for the time they spent to prepare the keynote presentations they made, and for sharing their knowledge and skills with us. And she requests you and me to give them a clap as appreciation for their time and commitment. The past 3 days have been used to reflect on the work we're involved in at various levels of the health sector in this country. The minister, therefore, wishes to thank all the stakeholders for the many positive changes that we have noticed in the sector in the last 1 year. Many of the changes, the positive ones, have been shared in this conference, and she says she's aware that there are many more things that have been done in the countryside but did not get here, but she appreciates everybody. The Honorable Minister is very sure that we have learned lessons from this conference, and she advises that we should go back and implement, and where possible, scale up the best practices that have been shared from other parts of the country in this conference. The issue of focused leadership and teamwork continues to come up in every review like this one as a driver for change and improvement. She therefore calls upon all officers in positions of responsibility and leadership to be more actively involved in quality improvement activities. The minister says she wants to see improved documentation and reporting by the quality improvement teams, especially those responsible for maternal and perinatal death audits, and those that are responsible for medicines management and therapeutics, and the teams that are responsible for infection prevention and control. She wants to see improved documentation and reporting. The current increase in teenage pregnancy requires action to reverse the trend and to protect the girl child. We are also being reminded by the minister to have our focus more concentrated on disease prevention and control through strengthened primary health care interventions. The minister says COVID-19 outbreak is still a big challenge in the country, just like in other parts of the globe. And our health service system is still facing the stress that COVID has come with. The progress made so far in preparation for active case management and prevention and control against further spread of the virus has to be sustained and even made better. That is her call. Most of our current efforts are directed towards implementing strong vaccination campaign against COVID-19 across the country. The Honorable Minister wishes to call upon each one of you to be her ambassador in this struggle so that we can have confidence to enter the new year with the majority of Ugandans vaccinated against COVID-19 infection. We continue to work under limited resources in our health sector, and the Minister calls upon our partners, those who are here and online, and the other stakeholders, to make more resources available through the mainstream. She wants the resources channeled through the mainstream, however small they may be, because they add more value. This is particularly important for integration and sustainability of interventions made in the country. Honorable Minister says as we return to our various working stations, she reminds you to be accountable and be responsive in giving care and support to our clients where we work. The Ministry of Health is committed to revamping functionality of lower level facilities, and she's calling for your support in doing this. More resources shall be committed to improving the status of health infrastructure in the different parts of the country. Because these changes to take place, we need to commit resources. We have to remain accountable and responsive to ensure safe custody and effective use of all these resources that are entrusted to us where we work. As she concludes, she once again appreciates all those that have enabled this conference to take place successfully, the committee that has worked so hard, the partners that made the contribution, and all of you that spared time to be here, to prepare papers, and to go through all the processes that have made this conference successful. She says, as you know, we shall soon be entering the festive season to mark the end of the year. And we should all make efforts to remain safe. That is her caution. Make every effort to remain safe, even as we begin the celebrations that are coming soon. She wishes you all God's blessing and journey mercies as you travel back to your respective homes. It is therefore her sincere pleasure and gratitude to declare the 8th Annual National QI Conference officially closed. And she says, Merry Christmas and Happy New Year 2022 for God and my country. Honorable Jane Ruth Acheng Ochero, your minister. Thank you very much. Thank you.
Could we
May I humbly request you to stand up and we honor God through this prayer. Let's humble ourselves for this word of prayer. The Almighty God, you who in your wisdom created the heaven and the earth, We thank you for loving us and for all your provisions and blessings upon our lives. We thank you for the protection that you've given us throughout the 3 days we've been here in this conference. We thank you for all the discussions and all the knowledge that we have attained during these 3 days about quality improvement. We now want to ask you to give us wisdom to be able to carry this back home in our different areas of work and be able to put them to practice so that they may lead us to improve services in this country. Lord, we pray that even as we depart from this place, you continue to give wisdom to our leaders, especially the President of this country and our Minister of Health, so that they may continue leading this country and the Minister of Health and all the people of this country into good health for the betterment and development of Uganda. We commit our journeys into your hands. Be with us on the road, up to our homes, and even bless us through the weekend so that we may be able to start the new week in vigor and with full strength to continue serving the people in this country. We bless your name, we glorify your name, and we thank you for loving us. In Jesus' name we pray. Amen.